Wabula Nelly from Luwero District Local Government. I'm a public health nurse.
You're very welcome. During the break time, please take time to ask Mr. Frederick Makaire why Luwero District Local Government is in here. But just in case you may forget, Luwero District Local Government is the only district local government in this country that passed an ordinance for community health financing. It was planning to make sure that each and every person who is resident in Luwero undertakes community health insurance. And it is no surprise that STREAMLINE will be launching in Luwero as well.
Yes, good morning. Wazima together. I'm Lubega Andrew, Community Health Insurance Coordinator from Chiwoko Hospital.
You are very welcome.
Good morning. Wazima together.
Wazima together.
My name is Rodrigo Patrick, assembly line technician for Signalytic. I'm currently here representing Mugabe Elvis, as is Nyezuwe here.
Thank you very much.
Wazima together.
Wazima together.
Happy Ash Wednesday.
Same to you.
I'm called Sister Maureen Kemjisha from Ruhara Mission Hospital, Barara City, Angkori Diocese, and I'm here as a CHI manager.
You're very welcome. We can increase the speed just in case the minister arrives and we just interrupt the introductions. It may not be good for Dr. Andrew Sechitoleko from Nsamia Hospital if he does not get to introduce himself.
Wazima together.
Wazima together.
Amos Bariashava. I'm one of the directors of STREAMLINE Health Technology.
Thank you very much.
Wazima together.
What?
I'm by names of Sister Josephine Nalwebuga from Villa Maria Hospital, Principal Nursing Officer.
You're welcome.
Wazima together.
Wazima together.
Aloysius Waswachimboa Bakochoiga, PR of Villa Maria Hospital, serving as the CHI manager. Thank you so much.
Thank you. Next, the trouble will be during break time when we ask what Wazima together means and you say truth together.
Wazima together.
Wazima together.
I'm Dr. Serwada Peter from Chiwoko Hospital. This is in Nakaseke District. I'm medical director.
You're very welcome, Doc.
Wazima together.
Wazima together.
My name is Moses Wawero, and I'm from...
Sorry?
My name is Moses Wawero, Senior Program Manager at Vilgro Africa. We are one of the investors in STREAMLINE. Thank you.
Thank you very much.
Wazima together.
Wazima together.
My name is Madi Groman. I am also from Vilgro Africa.
Are you coming from the same organization?
Yes.
Because you resemble in the face. No. But go on.
Yeah. So STREAMLINE is one of our portfolio companies.
Oh, you're welcome. Thank you.
Wazima together.
Wazima together.
I'm Dr. David Oponya from Uganda Medical Association, and I'm also the director of numerous medical centers, Gulu City and Nwaya District. I think we are ready to pilot STREAMLINE health activities in the northern region. Thank you.
Thank you very much. Next.
Ladies and gentlemen, Wazima together.
Wazima together.
I'm Dr. Lukabo Henry, Medical Superintendent, Chises Hospital.
Wow, you are very welcome, Doc. Doctor, you stand up again. The person who replaced Dr. Ian Spielman, the other side, almost the same height, but it's okay.
Wazima together.
Wazima together.
My name is Patrick Mugisha, but you can call me Mugi. I love that, so that to differentiate me from Sam Mugisha and another Mugisha somewhere. I'm managing partner Innovent Labs Africa, where we focus entirely on supporting the aspiration of innovation and entrepreneurship across board. And I just want to thank Chisizi Hospital, because they seem to be predominant here. You're so close to my heart because 22 years ago, you were able to look after my late grandmother, though we lost her. But thank you very much for what you did last time. So this is really amazing. And I think I come from Kanungu district. So please, before you go to other districts, you first cross to, I'm just there. I'll be able to engage the local government to make sure that we have the initiative in Kanungu district. So don't go far. Before you go to the north, Kanungu is just close. Please, thank you.
Thank you very much. Kanungu district and Gulu city on Woya, these are very strategic speakers. You see, Dr. Samuel must be taking notes very clearly because they have said they are very ready. Why would you go to a place which is not ready when they have assured you their readiness? Dr. Patrick?
Wazima together.
Wazima together.
Yeah, I'm called Dr. Kechan Patrick. I am the Health System Strengthening and Membership Manager at UPMB, and very much involved in promoting this. Having worked in a rural hospital a long time ago, it was a journey, and the only way I managed to improve it was the use of Excel. I had to learn it very well to manage finances. But it's good to have a system in place. And we started promoting this in our network, and we are looking forward to promoting it further in the entire network. Thank you.
Thank you very much. Dr. Kirechan's Rural Hospital is Kuluva Hospital. It is now, I think, near the city of Arua. Is it still rural? It's almost rural. Okay, next.
Wazima together.
Wazima together.
Good morning.
Morning, how are you?
I'm fine. Just removed my wisdom tooth, but okay. My name is Andrew Kibedi. I'm here to on the benefit of UPMB and Dr. Patrick. Just finishing after 3 years of fighting to build a hospital in Ibanda Kasese up in Rovanzore. So I represent also a charity called Children of Rovanzore.
Oh, you're welcome. Thank you very much.
Wazima together.
Wazima together.
I'm called Christine Makobole, and I work with Uganda Protestant Medical Bureau as a health financing specialist. If you cut me, my blood flows with community health insurance. And Kisizi scheme, my backbone is made of Kisizi scheme, so I'm really at home. You're most welcome.
Wazima together. My name is Martin Owo. I'm the IT officer at Uganda Protestant Medical Bureau. I'm glad to be here.
Thank you very much.
Wazima together.
Wazima together.
Dr. Andrew Sechitoleko, Chief Executive Officer, Zambia Hospital. Thank you.
Dr. Andrew, you're very welcome. And I need to add that please make sure that in addition to attending and participating in the launch, you make sure you get the contacts of the key persons in this room. And that's the reason we are doing introductions. So if you don't take the card for Dr. Spielman and then you want to have Streamline in your hospital, that's up to you. But if you don't take the contact of Dr. Sechitoleko and you get in Zambia and get stuck at the emergency, it's up to you. You just simply tell him that we met in Wazima together. Do you remember? Yes. Next.
Wazima together.
Wazima together.
Happy to be here. Epenyu Andrew, Deputy Director, Salem, Uganda, Kolonyi Hospital.
Thank you.
Wazima together. I'm called Catherine Kageni, the hospital administrator, Kolonyi. And Kolonyi is very, very grateful to Streamline, Surgeries, and UPMB who have moved us.
Wazima together.
Wazima together.
I'm Ashimo Sukira, Community Health Insurance Manager at Kolonyi Hospital, that is Mbale District. Thank you.
Wazima together.
Wazima together.
Stephen Wandera is my name. I work with the Manifesto Publications. Basically, we do magazines, mostly for government institutions.
I hope the people next to you heard you, but I struggled a bit. But you will introduce yourself better during the break. Huh?
Good morning.
Morning.
Wazima together.
Wazima together.
My name is Ansel Ochinobwire. I'm the founder and CEO of ANSIWorks. We provide professional business development services to organizations. I'm happy to be here. Wazima together.
Wazima together.
Thank you so much.
Good morning.
Morning.
Wazima together.
Wazima together.
Yes, my name is Wensi Benda at SJ. I work with a USAID project that is called Uganda Health System Strengthening Activity as the information systems team lead. But I've been a software engineer for over 10 years. And like my colleague said, I also hail from Kanungu district. And more than 10 years back, I also pioneered a community health insurance system for Bwindi Community Hospital. It is called Batakatwetambire. So community health insurance systems is also at the core of my heart. I'm glad to be here. Thank you.
Thank you very much. Before the next presenter, we have another person from USAID, Uganda Health System Strengthening Project. Dr. Kalejeya came in just when we were doing the introductions. Dr. Kalejeya, please stand up. He's there with us. And we will not come back to that table, but Dr. Kalejeya will be talking health financing. He's the health financing team lead of Uganda Health System Strengthening Project. Dr. Kalejeya, you're welcome. Next. Wazima together.
Wazima together.
Wazima together.
I'm Eva Sinatrina from Kisses Hospital Health Insurance. I'm data crack. First of all, I thank God for having won the award. If it was not that, all of us wouldn't be here. And great appreciation to Dr. Ian and Mr. Sam, the director. Thank you.
Thank you very much. I normally joke with Mr. Frederick Makaire that even if we are promoting community health insurance, we are not generally thinking like community people as such. So the energy in our speech should be non-community. Not that community is bad, but not community-like. So I prefer that we have more energy. Not that community is bad. Please don't misquote me, and I get trouble with people who are promoting community health insurance.
Thank you very much. Tesje Felix is my name, from Rushoroza Hospital, Kabale District. I work as a community scheme manager in Kabale Rushoroza Hospital, Our Lady of Good Health.
You are welcome.
Thank you.
Rushoroza is in the municipality, and they came in with another team seated somewhere around there. Rushoroza team, please stand up so that you be seen from Rushoroza. That is the senior nursing officer from Rushoroza, Sister Fausta. We know that Kabale is not near, though Rugarama came a little earlier, but we shall proceed. Next.
Thank you. I am Dr. Bekson Tayewa from Ruharo Mission Hospital. I work as the medical superintendent. I am a gynecologist. I am so grateful to Streamline because I think I'm lazy and I like easier ways of doing things. So I think Streamline makes work easier in electronic medical records management. I'm not like Dr. Patrick who uses Excel for everything. I wanted a software which can make work easy. That's why we took up Streamline at Ruharo Mission Hospital. Thank you so much.
Thank you, Doc. Streamline is for lazy people, or it makes work easier? which one, which one would you want to take? Makes work easier or for lazy people?
Let me clarify. Lazy people like easier ways of getting things done, but I was just saying that Streamline makes work easy, so that's why we like Streamline, so that we can concentrate energies on other important things. Thank you.
Thank you very much.
Good morning, ladies and gentlemen.
Good morning.
Wazima together.
Wazima together.
Edema Jimmy are my names, and I'm the health insurance coordinator from Bishop Asili Hospital. And I'm also grateful to be here to represent our hospital. And for Streamline, I'd say it has come timely at the time when we need to really streamline many things in our facility. So I also, there was the TOT with health partners, we in training provider, care providers in managing cooperative health insurances. So, and in the program I've seen my mentor here, Johnson from Health Partners. He has been a great champion in really getting hospitals on board to see how they can provide quality health care at affordable rates. So, and I believe Streamline coming on board, as I said, it will streamline most of these community-based health insurance schemes. Thank you so much.
Thank you very much. Later we shall give you an opportunity to give us the differences between health cooperatives and the Streamline's initiative of revitalizing rural health.
Wazima together.
Wazima together.
Wazima pamoja. I'm Dr. Eliud Mumbere from Kasese, in the mountainous area. You could have heard of the Rwenzururu Kingdom. I am the medical director of Kagando Hospital, one of the rural hospitals near Congo. Wazima together.
Wazima together. We have heard about Kasese, and we also heard about the new country that was in the offing but was stopped along the way. But we welcome Kagando Hospital team.
Wazima together.
Wazima together.
I'm called Janet Kasenyi. I'm the scheme manager, Kagando Hospital.
Kagando, you are very welcome.
Wazima together.
Wazima together.
I'm Juliet Nazibanja Chibirike. I work with Save for Health Uganda, and I'm the programs manager.
The national promoters of community health financing in this country. Next.
I want to say it the political way. So when I say Wazima together, I will put up my hand, and then the house also puts up their hand. Wazima together.
Wazima together.
Wazima together. Wazima together. Thank you. Doctor, it seems people haven't had a cup of tea, so the hands even can't get out of their shoulders to be up. But you're almost welcome. I'm Johnson Andinda. I work with Health Partners Uganda as a program manager responsible for planting cooperative health insurance schemes in the country. We will add on more later on in the day. Thank you. Wazima together.
Thank you very much, and I will excuse the next team from introducing themselves. We are going to go right away into the next session, and I would like to invite Professor Freddie Sengoba, who is going to be our keynote speaker for today's launch. Professor, you are welcome here. Like I told you earlier, Professor Freddy Sengoba is a professor of health policy and health systems management with over 25 years teaching and research experience. Professor Sengoba led the consulting team that developed the road to the universal health coverage, the roadmap to universal health coverage in this country. So he will be mentioning the road to UHC off the back of his palms. Professor has a doctorate covering the intersection of public health policy and institutional economics and systems management from the University of London. He is also the chairperson board of governors for St. Francis Hospital in Zambia. St. Francis Hospital Zambia is one of the largest hospitals in this country, with over 800 staff on its payroll. So he's also leading as a chairperson board. And from these engagements, Professor has published several books. I've told you the roadmap to UHC, journal articles, and has worked on a couple of things to do with financing. Please join with me to welcome Professor Freddy Sengoba. Professor, you're welcome.
Thank you so much for those kind words, MC. Let's see whether we are still able to. I grew up in, I should say, I went through Lumumba Hall and we used to make a very big salute. Wazima together. Hey, the people need some breakfast, I don't know. Let's see whether they have the energy enough. Wazima together. Great. So, ladies and gentlemen, welcome. MC, I can't thank you enough for the kind introduction. I recognize in absentia our chief guest, Honorable Frederick Ngobi Gumaf, the Minister for Trade, Cooperatives, the Permanent Secretary for the Ministry of Health, Dr. Diana Atwini, the partnerships that have brought us together here, the Swiss Re Foundation, UPMB, the Uganda Protestant Medical Bureau, and the Catholic Medical Bureau, Kisizi Hospital, and all of the partner hospitals that have had here present, and all colleagues here present. I salute you. So I am really privileged. First of all, allow me to thank the organizers for inviting me to be the keynote speaker at this very important occasion. So the Streamline, I missed the Streamline when I was mentioning the partners. I should have, so Streamline is also enjoying in the partnership for those that I was talking about. Thank you for inviting me here. I had opportunity to talk to the managers and they told me about what we are launching today. So I've organized my talk to cover mostly where we are as a country as it pertains to improving social protection, in particular financial risk protection, which is vital to universal health coverage. I'll talk briefly where the policy frameworks are. I've also been a consultant in trying to understand why our policy for national health insurance has gotten stuck. So I'll be sharing with you a few insights from that work. But in general, is to provide a context why community health insurance is the main entry point to build system readiness. As you know, when they tell you that the big boy is coming, and whenever the Pope comes, let me use the Pope because there are many other leaders, there are a lot of trials. How is it going to move? Where is it going to pass? Is the security, is the road, is everything proper? And so when we are preparing for big reforms, it's important that we understand which other reforms can come ahead to prepare the ground. And I've always been an advocate for community health insurance as a way of building the house. By the time you get to the national health insurance, you need communities that are already familiar with the concept, that have built the solidarity, that are able to understand the principles and obligations. And I believe it is that reason that we are here, to see that we're actually having a launch that is bringing on board a couple of important capabilities. One is the partnership to look at particularly hospitals. I know in the past, and I'll share with you, I think when I started as a public health, young public health, I don't know, I was not an expert, I would say someone who was just joining public health. We had an organization here called, it was called Population Services International. And there was a gentleman called Peter Cowley and another lady called Joy Batusa, and we were working, I think, for Partners for Health in the early days, going around hospitals to try and see how they can support them. So I was like an advisor at that point. I was a budding public health economist. So my early work was actually in cooperatives, going to look at how people can sell milk and put money into their community health insurance. And we worked a lot in the Western Uganda. Kisizi, I visited it about 3 times. Out of that, there was another innovation that grew up that came to Kampala. That was an insurance company that I now forget the name, led by a gentleman who was from Ireland. Who remembers the name? Microcare, wonderful. So I was there when Microcare was born. In some cases, I was the midwife, but it passed away, so I must say maybe we didn't take a good care of it. But the point here I'm raising, that we've had opportunity to see community health insurance in this country grow, and I am really very glad and happy to stand here today to see the rollout of, or expansion and reinvigoration of this area of our health system. As you've heard, they've told you that I also chair Zambia Hospital Board, and my CEO is there in the room. So we are part and parcel of the family. I know we are probably excluded for obvious reasons as in Zambia, but I believe we shall join the path as we go. The other element I want to share with you before I start my slide is that I also, because of those interests, I realized the PNFP hospitals were a big area of reform, especially when performance-based financing came on board. Government started giving PNFPs grants in the early 1970s. 1970, was it 1970? 1997 when PHC grants started. Out of the World Bank loan and poverty forgiveness of debt, that was HIPIC, called it HIPIC at that time. So that money was very helpful in trying to set up PHC. And then PNFP started getting a grant in addition to, from government. But in the process of doing so, hospitals were being asked to show cause, how they are using the money, how they are removing the fees, and how they are improving performance. And I took that cue to go and do my doctorate during that period in about 10 hospitals, and I'm happy that Dr. Patrick Achan is here. He was managing Kuruva Hospital and was one of the 10 hospitals that I used to collect data in, and they are the ones that really shaped me into this field. So a bit of gratitude to this community of community health insurance for what I've eventually become, and probably the reason I'm coming here is to give back. That said, let me now take you through my presentation. So I was told this is an innovation on many scales, in terms of trying to combine health insurance at community level, but working with hospitals and therefore management improvement and strengthening for decision making at hospitals, but also trying to manage the insurance system. And as you can imagine, those are 3 complex interventions. But I'm told because of the complexity, they've also put a learning program into it, which is research to understand how these developments are taking root. Those of you who have met me, I always like talking about complexity in health systems, and this is really the place I want to be, because when you engage in such complex interventions, it's important that you have a learning agenda, it's important that you have partnership, it's important that you have data, it's important that you leverage technology. And I see all this here, and for that, I want us all to join me to congratulate the innovation and partnership for this wonderful project. I don't know where to point for this to move. Okay. I hope these have not blocked the signal going through to the system. Can you help me move the slide? So broadly, we are in the context of UHC and or universal health coverage as a global community, and this comes out of the Sustainable Development Goals. And as a community of health practitioners, community of health development people here, and of course service providers in health, our call is to try and operationalize these elements of UHC. Broadly, it's about leaving no one behind. It's about ensuring that the needs of the community, especially those that are more vulnerable, unable to meet or to get their care given, are put ahead of the queue. It involves ensuring that the population has the services that they need. It involves that more services are made available, that fewer people are being put into hardship because of paying for healthcare. And of course, it's about equity. How can we do this? By ensuring that the most vulnerable are ahead of the queue instead of the back. And as you know, in our setting, usually it is the law of the jungle. If a new program comes, some of you in the room may get there before some of the people in the villages where you came from are able to even know that it is here. And that is the challenge we needed to address when we are talking about UHC. Next slide. Can we see if these metals here have to be moved? There are many countries that have led this road and have given us examples. I don't plan to go through all of them, but it's important to note that there are countries that have shown that the whole issue of social protection, particularly financial risk protection and catastrophic expenditures, can be lowered over the years. And this graph comes from Thailand. Thailand is one of the countries that started way back in the early 90s to try and build a community health insurance, which community insurance were eventually merged over the years to become a national health insurance. So we also learned, one, the pathway to how to build this social protection. Many times you need to start small, get the engagement at the community level, and over time try to build synergy and of course aggregate them, and at that point, by the time you do a national level, there is a general uptake and understanding of how it works. And that is the way Thailand have taken it. They've shown a lot of leadership in terms of governance and technical leadership. They've also been committed in a social protection area, so health benefited from that. So this journey, I think, tells us two things: that it's possible, and yes, we may need to also grow our economy to get there, because they had to grow their economy. But what is important is that in their country, they have almost 17% of the national budget goes for health. And that is very important context as we talk about resource allocation. We needed to also pay attention to what needs to be done in terms of building the platform with public funds and building the services with the contributions. Next. UHC, now part of the region, is an area I wanted to quickly identify. If you look at indicators that are essential, I also can't read them. I thought I'll have an advantage over you, but I think some of these are to do with stunting on top with the yellow. Next is maternal mortality. Then you have under 5 mortality and the like. If you look at these are critical indicators in terms of where we want to go. You will see a line, a small line on each graph, down or up, depending on when the target is. Important message out of all of them, that the trends are facing in the right direction. In other words, we are moving towards the target. But if you look at the time frame, they are all slow trend development, meaning it will take longer than 2030 to get there. The other element is the blue, which I've put there, the arrow, to give you the gap, where the gap is. So some gaps are big, some gaps are small. That also is to speak to the fact that some areas require more work than others. But broadly, we are not moving at the speed we need to be moving at, but the good thing, we are facing in the right direction as far as UH is concerned. Next. Next slide, please. In terms of causes of morbidity, or what is really taking our health funds, but also disabling the communities where we really need to do more work, is to appreciate that malaria is still big, pneumonias and the like when it comes to admissions. When it comes to causes of death, you can see a mixed bag there. Malaria, pneumonia is also there, anemia and others. If you look carefully, you'll see that many of those things we can do better in prevention if we put our efforts together. And I think today is also a challenge for us. We want people to put insurance to access care, but we also need the insurance for well-being, which keeps away the population from care. I don't know if that message is clear. So meaning we need to work on two fronts. We need to encourage communities to save and be able to receive care when they need them and we need the care, but also we need to ensure that we generate money as a government, particularly public funds, to prevent these illnesses so that the communities do not have to spend time seeking care, or the funds like community health insurance do not have to go bankrupt because the need for care is too much. How do we work on these two agendas is a challenge I want to leave to you, but it's important to recognize that if we work in one space alone, chances are we may not be able to create a sustainable and feasible outfit in terms of community health insurance. In other words, you have to get the tap closed if the community insurance and national insurance is to be sustainable. Without that, we may not succeed. Next. And of course, when we talk of well-being, we need to appreciate the fact that, yes, health is made from so many dimensions. People say made at home, but actually made in the community. I believe that the road that might create a bump and somebody may run off because of a pothole and hit you, that is not health made at home. That is in the community. How can we ensure that issues of social cohesion, we see a lot of conflicts and people die in Congo, and I don't want to use examples here, but DR Congo is a good example. So many people are dying out of conflicts. The economy has to be right. People need to get employed, stress at work, people are having 4 or 5 jobs, sometimes people are missing jobs and going into mental health. Housing, I don't want to tell so many stories here, but if you followed what has happened in Turkey, you see how housing can be a source of health determinant and also a determinant of death. I think almost 50,000 people have died there because houses were constructed poorly and they all collapsed. The other aspect is about, okay, safe transport is okay, environment and environmental stewardship. I think this is very clear. When you're breathing very bad gases or contaminated air, you start getting asthma and other infections can come through and you come back to seek healthcare. So in general, what this speaks about, we need to have negotiation with other actors in the society about these determinants. As we take care of those who are sick, how do we also go to these duty bearers to see that they are doing their part? And I think health, we've been very poor at reaching out. As a doctor, I think I was trained to receive patients, treat them, take good history. But I was not told to go and talk to the road engineers and tell them what it takes. And the road engineers also don't talk to public health people. But when the accident comes, the police brings the cases and we struggle to manage them. Another one comes until maybe politicians decide that something needs to be done on the road. Rarely do you see public health leaders leading this discussion. So we really needed to work across board and especially improve promotion. Point being, we really need to improve health from many angles if we are to succeed and build resilience in the system. Next. What I think is a familiar story to most of you in the room, since I had most of the introductions here from health sector, is this. This story is really when people in the community feel they are not well and they need to navigate and get care. The commonest reason people get disappointed or frustrated with this journey is the inadequacies that are not in the system. Not finding the diagnostics, not finding the medicine, sometimes not finding the staff, and sometimes not having a clear referral. As you will see down there, the referral is to the private sector. The private sector is also going to insist that before you come, you have to show cause. Where is the money? And the money is not likely to be little if especially the conditions are that they are spending money to provide those services. I've been running a hospital with my colleague here, Dr. Andrew. We are a hospital that is depending on client funding. And we are always having this challenge of trying to balance, taking care, especially of the poor, at the same time trying to ensure that what we provide is pays for itself. Otherwise, we don't have another way to survive. So there are institutional challenges in there, how people are navigating the system, and the system that has both public and private. Policies that might indicate free care may not actually be free. And that is the reason hospitals like in Zambia and many of those in the room survive, that the public has not done what it promised. And of course, when people fail to get the money, they go to look for the money and the illness keep going worse. Sometimes they may stay away waiting for the money to accumulate. The disease also becomes severe, and by the time they are picked and brought to us, they are not capable of even speaking to themselves. Maybe they are too sick. The care is maybe many times more expensive than the first time they tried. And yes, they may have to part with a plot, a bicycle, a goat, a chicken. So many of these stories are there. When I was studying, I used to find most hospitals having a store for bicycles. I don't know whether it's still there. But the reason hospitals had stores for bicycles, they would confiscate the bicycle of the people who are coming to pick the discharged patient until they've paid. So the bicycle will be put into a store until money is brought. The patient will be kept longer. I believe these have maybe changed, but I can't be sure. But the point is this: the dignity, the risk, the catastrophic health expenditure come from this story. But also from this story, we can start to see where we need to work in terms of making this navigation more able to have financial risk protection is one starting point. Ensuring quality is acceptable at all levels of care, both government and PNFP. Ensuring that costs are affordable where possible. Ensuring that referral patterns do also speak to the capability to pay. But also, increasingly, as we see it, we really need to advocate for programs like community health insurance, so people have prepayment. We also need to advocate for government to put in money, and we need to advocate for good and well-wishers to support, especially the poor. Next. So broadly, I think generally we have these policy options when we talk about social or financial risk protection. In Uganda, I think the issue has been about keeping the status quo as we know it. As we know it is not really very progressive. There is still a lot of underinvestment and slow progress, as we've seen. The second option is expect more from donors, but also donors are telling us it's time to transition. Many of them have transitional plans. Within 3-5 years, they want to see their money going down and domestic financing going up. But also the resources from this source have always been unreliable. They may give you a 3-year grant. When it ends, you're not sure whether it will be renewed, or you have to shop for another donor who might come 5 years down the road. And in there are a lot of changes in the services we are providing, because this has gone away and a new one is coming and is not delivering that one. It's changed the package of care. And these are the constant implementation dance that we have on the ground. As a hospital manager, you may not know whether this service you have now being supported will stay next year and 2 years from now. The third option is the National Health Insurance, which we've been talking about for the last 20 or so years. We believe the main issue or problem right now is the blockages that we have in the system. The Parliament has passed it almost twice and has been blocked twice. But in between, there are almost 10 years that are lost in there. Currently, we've been told Parliament is going to consider it last year. I'm not sure how far we are going. So uncertainty still surrounds this policy. The last one is the one we are at, trying to promote and or support community initiatives, especially community health insurance and prepayment systems, so that we have smaller pools. They may not be as efficient as big ones, but the fundamental advantage is learning early and also community solidarity, which is viable at that level. Next. So why this policy has delayed, I think I've already talked to it. This, for things that I couldn't say, I think cartoons are good at capturing this. So, as I told you, I did some work to understand why the blockages. But there are so many decision points. They negotiate for 100 of them, they turn green, another 200 emerge. And then negotiations, then people are sent back to consult. They consult and clear another 200, then another. And so as a community that is interested in community health insurance, we really need also to see how this process is moved forward. I must also give thanks to USAID Health System Strengthening. They are the ones who commissioned me as a consultant to look at these blockages. Next. So I've talked about the recurrent roadblocks, but what are those in general? What is in the meat of this? So generally it's about poor quality services is the number one. Every time policymakers, especially the top ones, Mosei in particular, he says, but these services, this bill, is it going to make me lose votes? How is it going to play out in the rural area? And in the rural area, as you understand, that's where the system is weakest. But this is where the votes are majority. So when you look at the political economy of this animal, ideally we need to pay attention to how services are experienced by the remote. Issues of cost and business, especially to employers, is a key issue. Deductions on salary. Employed workers like me are always complaining. Every deduction comes to the employed. Those who are having their cows, hundreds of them, they are paying nothing because they do informal trade. And of course, who deals with the indigents, those who can't pay, is still a big issue, and finance has been back and forth on this issue. These are important areas for us to pay attention to, especially if we are to try to understand what upstream policy will require in order to move. Next. I've been warned, so I'm going to move faster. The other element that is actually cardinal to this is how the bills have been developed over time, but also how they've been designed. And this people-centered design issue, I think, is a very important one, and I'm very happy when I was being asked to come and talk to you today. I actually did interview the team that came to me trying to figure out how they've designed their work, and I was very amused and very happy to see that they've actually taken a people-centered design. And I think they deserve a clap. What is this people-centered design? Many times when you look at how we make policy, we sit in boardrooms, sometimes we commission a consultant to talk to who is important, and we come back with what should be done, only to be shocked that the players on the ground are not aware. Let me ask, those of you who are in the room who work in a hospital, how many of you have attended a consultation meeting for the National Health Insurance Bill? Just put up your hand. So I see one. How many of you are from hospitals and managers at that? I think that gives you a sense of what I'm talking about. People-centered design, you need to ensure that legitimate duty bearers are the first ones to be part of the consultation. And this is not happening. So the time the bill is passed in Parliament, then they will come to talk to you. And then you will raise new problems. And if the Muzee is listening, then you say, oh, go back for consultation. The doctors are not happy. I think you see the problem we have. So this is very important to ensure that it happens. One, you have to build legitimacy. One, you have to ensure that there is sense making which allows all players to contribute their concerns, their capability, and see how you can tie that and make a design that is able to achieve sustainability and feasibility of implementation. And these questions I've laid here, I may not go through all of them, but these slides will be available to those who want them from the organizers. You can engage with them, but critical among them is the set of community readiness for social solidarity. When I went to Kisizi when I was very young, I went there the first 2 times and I didn't understand clearly the Kisizi model. But after taking a bit of time, I also climbed the hills. And when I climbed the hills, I actually started understanding what community solidarity is all about. And this is not to say that topography is the most important, but when you are in Kisizi, you realize that you cannot be sick and move down or up the hill, whatever the health center is. The nature of the terrain is that people have to help you down or up, depending. And when I was there, it was about 2 weeks, and we had the opportunity to also lift the woman who was pregnant down to the hospital. And the more I reflected on that experience, I realized that we sometimes don't take all the factors into play, but it's important context to play a role. And as we go to the 15 hospitals, it's important that for each of them, we appreciate the context they have. And what are those contextual factors that are able to build solidarity? If it's not there, how do we seed the ideas? How do we become agents of doing so? But please pay attention to context. Because if you don't, chances are you may not understand why people are not either coming or they are rushing in. I'll stop there and move to the next slide. So there, and when it comes to financing in particular, I wanted to draw your attention to a recent publication which I very much value, and I believe if you have not engaged with it, you'll find a lot of value in it. This is the Lancet Commission for, this is high quality. I think I must have missed this. I think I put the wrong picture. There is a Lancet Commission on people-centered PHC services led by Kara Hansen. Apologies for the wrong one. This is about quality. Next, please take time to look at it. Next slide speaks to the key findings that come out of that report. One is the fact that we need public and pooled financing. And pooled financing is, for example, community or national health insurance. And in there is issue of equity, issues of sufficient flow. That is important. And it's important to look at for sufficient flow. Money can be generated but may not get to the provider at the right time. Sometimes even billing can be a challenge. Microcare, I think the reason it struggled is these processes were not happening very well. So people got insured, were initially given a red carpet, but after some time the carpet was moved to those who are paying cash. And those who were in the insurance were delaying almost 4 or 5 times. So with the time, people stopped getting into that, meaning we need to pay attention to those issues and how they flow. Whole of government is important. So we really need to work with local government. We need to work to community health work, community leaders. They are part and parcel of this. There may be village health teams. There may be religious leaders. They are key people, especially to work with when mobilizing for community insurance, but also ensuring multi-sectoral actions that are supposed to reduce the burden of illness. And of course, draw the path for UHC rooted in local context. I've already talked about the importance of context. They need to reform standards, both for financing and financial data. And I'm glad you are working with a data software package here, which is helping this, so it's going to be important. And of course, research, learning as you go. So those 5 are the key elements that come out of those. And when I looked at what is being proposed, I realized that these 5 grounds are well catered for as far as the Streamline Ubuntu is designed, the innovation. So congratulations. Thank you. Next. So as I come to an end, I want first of all to commend the partnership, as I've already talked about. Many things happen not because we are smart individually, but because we pool the capabilities. When I teach, I talk about the problem of distributed capability. And I support Arsenal, and every time Arsenal wins, I'm watching the match just to see which capability didn't work. Is it the goalkeeping, is it the defense, midfield, or the attack? When you understand that you have different capabilities that make the team win, it's important that we all pull those capabilities together. And it's always a task that is not given a lot of space in our work, but I'm glad to see that here, these capabilities are being pulled. We can see Swiss insurance, reinsurance. This is insurance plus. I will not go into explain what reinsurance means. I see IT specialists, I see hospital care, I see designs that are going into finance and financial advising, and of course research that is going to look at many aspects of impacts and progression in this. So I think we have put together a partnership in my mind that I believe is going to work, and in the new hospitals, it's important that you also start to build this partnership closer to you beyond this upstream partnership that Streamline is bringing. How do you build this partnership also around your hospital to ensure that this works? And this is important to do next. And lastly, I want, of course, to salute the scope. As a researcher, I was very happy to learn that there's going to be a very rigorous assessment of this intervention. Some of it is randomized trials. Those of you who know me, I am a fan of them. But in policy, I am not a fan. I'm a fan of learning how things happen and the politics of it on the ground. So I believe combining different research methods as going to be applied in this is going to be critical. So you have a rigorous approach and also approaches that are able to navigate day-to-day developments. And I did promise the colleagues that I'm going to sign up to be a follower. These days, I think on social media, they say you are following something. So I'm going to be following, not in a bad way, I'm stalking you, but as a supporter to see that you succeed, and where necessary, I'll be happy to come in and help. And I'll be looking forward to the evidence, because I believe this design is actually able to feed into the evidence that we really need to move also the national agenda, but also to share with the international community. Ladies and gentlemen, I want to thank you for listening to me, but also apologize in advance that I have another talk to give a distance away from here. I may need to get there, but let's join me to congratulate the partnership for the work done.
Another hand clap for Professor Frederick Sengoba. Thank you very much, Professor. And we have heard your apology. Ladies and gentlemen, I've been told that it's break time, and my co-MC has actually noticed that people are very hungry. After a keynote speech of this nature, we would normally have someone else to give a talk, but we are going to use this opportunity during break time to challenge Professor for some of the assertions he has made, to get a little more clarity for some of the statements he has made. We know that he's going to address members of parliament, and we are praying that he forgets and puts the same presentation when he's going to talk to them, then he realizes that it is a different one. So as you realize, Streamline is a technology company which is nearly 10 years old. It's a digital health platform. And some of you may be asking how technology is going to go into rural health financing. So we have a desk in the corner there where you're going to be told how Streamline links to community health financing or rural health financing. and it is headed by Titus Tumwine, who is a field support engineer, but also, I have learned a new word, he's a customer success manager. Not customer service, but customer success manager. So during the time of break, we shall go in that corner, those of you who wish, so that you'll be able to associate digital health, technology, and community health financing. Number two, for those of you who have folders, there is a document on the photo and video consent form. I request you to take time and read through it. In this room, we have journalists, but please be sure that what you're going to consent to is not for these journalists. We have NBS, we have NTV, the others are coming. What you're going to consent to is for STREAMLINE. STREAMLINE is a partnership with Church of Uganda, Chisizi Hospital, and I'm mentioning Church of Uganda for a purpose, so you can be assured that once you give us your consent, we shall handle your consent as faithfully as it can ever be. You will not find your pictures or your videos in places which I don't want to mention. Just be sure that we will keep them safe and confidentially. But also know that you can withdraw your authorization at any time, okay? So, those of you who have folders, please read through. And if you have any doubts or any questions, we are ready to respond. And lastly, I am going to request the medical director of Nkozi Hospital, which is going to be one of the beneficiary hospitals, to give us a prayer for break tea, which will last less than 10 minutes because we have an exciting presentation to follow. When I say less than 10 minutes, it is okay, we can come back with our cups of coffee, but I hope within the 10 minutes we can be able to connect with each other. Dr. Crescent, please stand and give us a prayer for break.
Let us pray. Bless us, O Lord, and these are the fruits which we are about to receive from your bounty through Christ our Lord. Amen.
Amen. It's a kind of a nice way to introduce someone who came in incognito, but it's okay. Can we break for break tea? Thank you for the morning session. When you invite people for break tea and they remain seated, you start wondering whether it's Ash Wednesday or something related. Dr. Ian Spielman is preparing to give his presentation, and as you can see, he's moving around to make his work ready. So when I give 10 minutes, it is real 10 minutes, and Dr. Ian's presentation will be next. Oh, the tea is behind the hall. And please take time to learn how STREAMLINE is going to empower communities for financing.
commissioners and senior staff, dear medical directors and staff members from partner hospitals and implementing partners of Streamline Health. It is truly my honor to be able to speak to you today about our work at the Swiss Re Foundation. My name is Stefan Huber and I am the director of the Swiss Re Foundation. Let me briefly introduce our work in Swiss Re. Swiss Re is one of the world's leading providers of insurance, other forms of insurance-based risk transfer solutions, working to make the
In the attempt to catch up with the time, I'm going to request my colleagues from Streamline to facilitate a process so that everyone has tea or coffee in the next 5 minutes. My colleagues from Streamline,
Thank you very much, you who is watching us live on Creative Digital Media. We are because you actually choose to listen or watch whatever content we actually have to put up. Another beautiful comes back to how that you are going to be calling an easy task. Now, Streamline Health is actually trying to facilitate clinical excellency when it comes with, when you go back now to the management of these health facilities, you're going to have a one-stop center Others, for instance, if we were to give that as a within the 9 months, someone is expecting a month, maybe at the time of delivery, then that is always going to be affordable, at least in one way or another. I would wish to talk to one of the of what this could actually be about. Thank you very much. You are welcome to. Oh, no.
We have to catch up with the time. But I also wanted Johnson to hear the story of Dr. Ian.
My name is Harrison Kangaho. I am a software developer at STREAMLINE Health Tech. I've been with STREAMLINE Health Tech for now 2 years, and it's a great place, I think, to work, solving real problems. Okay, STREAMLINE. Yeah.
We have these memes that usually run around.
Yes.
Clearly, developers, people who, of course, are going to be so.
Our next speaker.
What is it like?
Yeah.
Streamline.
STREAMLINE.
No stranger to Uganda.
STREAMLINE majorly being a social tech entrepreneur driven place. It's just it's more of engaging with people. So even in the back end, for us who do the coding, for us who do the programming, it's just there's a bit more we go through the process to develop code, solve certain problems for people that, like, for example, Chisizi, hands-on, we have to be there at the site to develop. As we are discovering problems, we are developing solutions with them. So it's more of a design-centric, we are designing with the people we are designing for. Yes.
Rose through the ranks.
So you got the design thinking very right.
Yes, yes. Yeah.
Until 2022. So he has been in Uganda for the last 35 years.
From the developer's perspective.
Yes.
And he came to Uganda with his wife Hannah.
I don't know. Of course, for us.
Yes, yes.
Just to be sure that you don't
We just know
Ugandanize
it's a platform that is going to help us, maneuver through
Dr.
struggles
Ian
in financing
serves
medical
as the
bills and
clinical
whatever.
lead
Yes,
at
yes.
Streamline
What
Health
is it in your
and is the
Uh,
international
okay,
coordinator.
Streamline Ubuntu for our context as programmers. We create this platform that makes it easy for 3 categories of people.
He has worked as a
The
pediatrician
hospitals, they have a fully functioning EMR.
both in Uganda
It's
and
linked
in
to
the
the groups, so groups can manage
And
their
one other thing
data.
that I thought
And
the
then
best
also,
I've listened
as
and
well,
taken
we
note.
provide a platform for business intelligence
Ian contributed
that
to the
is
four
linked with
methodologies and the laws
AI,
of
artificial intelligence,
organization
that can help you make informed decisions. Yeah, so we integrate this platform. We amalgamate it for all the groups of people that are engaged. So we make these solutions very easy and accessible for the lowest people. Yes.
So there now, because you said you're going to the user experience. Let's talk the user experience. What makes it stand out?
Okay. There are very many things that make it stand out. So the major thing that makes it stand out is, I believe, the impact. Yeah, the impact with which we are having in hospitals like Chisizi, yeah, Kagando, and a few others. There are, it has been a very easy thing to pass on to people who are not so tech savvy, not so computer literate. So we build with them as we are solving their problems as well. And then we make it so easy to use for the lay people. That's the user side of it, I think.
Okay, we will be switching back to the main.
Thank you.
Actually able to come up with different interviews here and there.
Rehabilitation and palliative care. And STREAMLINE is seeking to support those different areas to improve quality of care. I think you all know Hippocrates. I think you know what he said all those centuries ago. He said, above all, do no harm. Such a key principle in medicine. I think it's one that we teach all the medical students. Above all, do no harm. And STREAMLINE is trying to help avoid harm to patients because patient safety is such a crucial area. I think something's just gone off. What's happened? We lost the slide. Okay, it's on this one. This projector seemed to go off. Yes, I had the privilege of working in Kisisi Hospital for many years. And one of the interesting features of Kisisi is it was the only hospital in Uganda on the World Health Organization African Partnerships for Patient Safety. And that looked at a whole lot of different areas, including infection control, waste management, safe prescribing, and so on. And we followed on that patient safety interest over the years in a number of ways. And that included a document looking at universal health coverage and patient safety, which our keynote speaker reminded us was so important. And yes, we also have contributed to the WHO Quality Toolkit, which you can access online and which is a dynamic resource. But all of those patient safety aspects, we have tried to integrate some of those into STREAMLINE to help us in the front line every day when we're seeing the real patients. And STREAMLINE has all sorts of features, and I'm just going to pick a few highlights on the clinical side, and other people may tell you about some of the other functionality. So first of all, it's real time. We enter data as we see our patients and deal with them, and the data entry is by the clinicians involved with the patient. Now, some other systems use retrospective data entry with maybe data clerks, but that brings in the possibility of transcription errors, and it also may cause inaccuracy. Now, this approach that STREAMLINE has means that we can then have a 100% prospective audit of what's going on. And that is such precious data and so valuable. And again, the keynote speaker mentioned research and data to inform properly that we make the right decisions. And then STREAMLINE is very flexible configuration. So that within this room, we have people from many different units, including big hospitals like in Zambia and much smaller places. The needs are a little bit different, but we designed STREAMLINE so that it can be easily configured. We've integrated functionality to avoid duplication. One of the most common things that people say in the NHS about computer systems is they say, we have an X-ray system, we have a pharmacy system, we have an HR system, and they don't talk to each other. And we've tried to bring them together to avoid duplication and fragmentation. And then STREAMLINE is seeking to capture all the patient encounters. Now, there are some programs, for example, the program that many people use in ART clinics, in HIV services, which only captures those clinic visits. But if that patient with HIV goes to gynae clinic or goes to the dental clinic with an abscess, it isn't recorded, or it may be missed. And we saw a very sad, we heard of a very sad case where a lady had been attending an art clinic, but hadn't been recognized that she had features of carcinoma of the cervix. So bringing it all together can help to interpret and give better clinical way forward. And when we've done analysis of how the users have found STREAMLINE, it's been very encouraging because it showed 100% of users found it easy to use. Interestingly, yesterday I walked around SEBI Hospital with the STREAMLINE CTO, and all of the staff we talked to in all the different areas were saying they found it easy to use and were happy with it. So that was very encouraging. And we're now at a situation where over 600,000 patients have been encountered on STREAMLINE, with over 1 million actual visits recorded, and more than 40 hospitals engaged using STREAMLINE. So it's taken off and it continues to grow. So one of the features we look for is implementation. We're all aware of lots of guidelines and research, but the challenge is how do we make it happen in the front line when a clinical officer is seeing a patient or one of our staff? How do we make it happen? We have a big theory evidence base, but how do we make it go to the real world in the front line? And STREAMLINE can help that. Nigel Crisp said that it was the day-to-day difficulty of making things happen. And we're trying in STREAMLINE to help that process. Let me give you an example from mental health. The Emerald study was a 6-nation study, including Uganda, run over a 5-year period that looked at how do you assess and measure the quality of mental health services in low and middle income countries. And it came up with a number of suggested parameters. And we were able to introduce those into the special clinic template for mental health. STREAMLINE has a number of special templates for eye care, for diabetes and so on. And this means we can then generate reports that are very helpful to monitor what's going on in much more detail, because 100% of the patients are being recorded. And that can allow us to also look at specific diseases and track what's going on. And this is very valuable data to look at trends. If I take another area of pediatrics, most of you will be familiar with integrated management of childhood illnesses. The interface between those two, we have the ETAT, Emergency Triage Assessment and Treatment tool. And this is important for analysing which children are high risk. So this information from WHO is evidence-based and peer-reviewed. And so how do we implement it? It was adopted by Uganda as an algorithm to be used. So we've then taken it and said we'll use it in STREAMLINE, because in Uganda it cannot be seen in priority order according to need, but according to how they've attended. So in the pediatric triage in STREAMLINE, it incorporates the ETAT system, and it will make sure that the person doing the triage has assessed for a problem causing all sorts of health issues and social issues. We ask about smoking. We ask about the assessment of the patient's nutritional general clinic. Here, for an example, an adult had a positive answer to one of the questions, and a pop-up box has come reminding the staff to move the patient away from the queue and to make sure that a sputum test is obtained and a referral made. The clinician, when he sees the patient, will see that data and will be able to respond to it and assess the patient. And they're simply asked to click whether they think the patient has definite TB, possible TB, or definitely not TB. So it's only one click, but it requires them to have assessed the patient carefully. You all know about HMIS and the paper form, and we have got that in STREAMLINE, but the advantage of the data here is we can drill down, and this principle applies to all the clinical data in the program. So if you see a table like this and you see a figure, like this figure of 24, you can say, what is that? Who are those patients? And if you click on it, automatically it gives you that list. If you then want to interrogate further and drill down further and look at an individual patient, you can select that patient's record and open up their homepage with all their previous attendances, and you can then look at any of those in detail, right back to the individual episode data. So there's lots of important things on triage and screening, and another important area is resources. We have introduced one-click links to resources so that we can have the correct treatment first time. Here's an example of a patient with TB. So the doctor has put the diagnosis in, and there's a linkage is then offered, and if he clicks on UCG TB, one click opens the right page of that document. Or if he clicked on the WHO prevention treatment link, it will open that document. Here, for example, a midwife has clicked on preeclampsia and gone straight into a WHO guideline. Here, we also have done it for some procedures so that you can open up interesting background, and this can be also valuable in training so that you bring interest and stimulation and learning as people are working through. Another example is that in addition to the WHO and national data, we can also add local institutional guidelines, because all of us will have slightly different pathways. And here, for example, there's a link that takes you straight into the Kisisi psychotropic and epilepsy prescribing. So you can add your own links that your staff will then utilize. This is one of the patients that I saw who had been to multiple clinics and failed to improve in the community. And when she came to us and we treated her, she improved with her nephrotic syndrome properly controlled. And the reason was we knew the right regimes to use. So one of the things that STREAMLINE does is it provides a whole list of resources which can be categorized by different departments. So 24 hours a day, we can access these guidelines. And we all know that the paper guidelines get borrowed or moved and we can't find them. Now, when we look for a guideline, we are making a conscious decision that we want to look up something. That's because we know we need to check something. But a prompt is coming, even though I haven't asked for it, it's prompting without me knowing that I need to have that advice. Here, for example, in STREAMLINE, we have a drug, furosemide, and straight away a link, a prompt appears, which reminds us of some of the warnings and the indications and patients where we need to be very careful using that particular drug. We also see there's a reference link to the Uganda practical guideline dispensing, and it will take us, if we click on that, straight to the right page for that medicine. Now, this is streamlining the process. It means that when I'm seeing the patient, I need to check something, I do one click, and I go straight to the information I need for that context. And because it's so easy, we find that the staff use it. I smiled on one occasion. I got a phone call early morning when one of the doctors rang me and said, "Dr. Ian, STREAMLINE's not working." I said, "Well, what's the problem?" She said, the program's working, but when I click, it's opening the document, but not on the right page." And it turned out that somebody had maliciously uploaded some software for PDF download in the clinic overnight, and it had interfered, but it wasn't a problem with STREAMLINE. But what it told me is she wanted that functionality. She wanted, and she missed it when it wasn't there. So we think this improves clinical quality, and we're pleased. So for example, if I have a patient with interception, we'll get the prompt that reminds us about aggressive fluidation being important, and so on, and it will also give us the references. And you can add your own, as I said earlier, that's important. In addition, STREAMLINE has an alert box where you can put any free text message. So for example, if we were operating on a patient and we found that the patient had a difficult anesthetic because their airway was difficult, we can record so that the next time that patient comes, don't have the most junior clinical officer doing that case, but we get the most senior people available because we're warned that there can be a problem. So use the alert box to warn your colleagues because it's available 24 hours a day on that record. So we have immediate access to the previous encounters, and we can also store documents that are valuable. Here, for example, is a chest X-ray stored against a patient. This is a JPEG photograph uploaded onto STREAMLINE. But it's very useful when we're tracking the progress of this patient to know that initial X-ray, and we can store other data that a patient has had a previous biopsy and nobody can find the result. So bad, because you then have to potentially repeat the test and it delays. So having it available on the system is really useful. When we look at the laboratory, we all want accuracy and we want timely investigations. And STREAMLINE will now take results directly from some of the modern analyzers into STREAMLINE. It may not work on the older ones, but it's working on the new ones. And in fact, yesterday at FEB, I saw that in action. We've built into STREAMLINE authentication checks for the laboratory and for pharmacy. This means that there's a second person, usually senior, who's checking. So, for example, in the laboratory, if the initial result comes back with a very high potassium, it is not released to the clinician immediately, but it's checked. And if the senior lab person says, actually, this was a hemolyzed sample and this is not an accurate potassium, it is not released. Had it been released, the clinicians may have given this patient all sorts of treatment that may have harmed them. And we all said, do no harm. So these safety checks are also for the medicines where the senior person checks that they're correct. Now in the laboratory, with paper investigation requests, you tend to get sequences where the samples go through department by department, which takes time. And then the paper result is released at the end. But with STREAMLINE, we can run the test parallel in the different departments. And that's quicker, and the results of those tests can be released immediately they're available. So the investigations produced by STREAMLINE are in different groups, such as biochemistry, hematology, and so on. The person requesting the test can indicate with a slider whether or not it's urgent. And if it is, it will put a black triangle against that test. Now this contrasts with the paper system, where I don't know how many of you, when you're doing paper investigation requests, have your staff just putting a big X when it's urgent? Yeah, so the problem is, if you have a big X on the form and it's got lots of tests, how does the lab know which ones are the real urgent ones? They can't tell. But here we can differentiate. We can say this test is the one I want now. Moving on to medication, the WHO Global Patient Safety Challenge talked about how important medication without harm. So STREAMLINE includes allergy information, and if a patient is recorded as being allergic to particular drugs, they cannot actually prescribe that medicine. It's impossible to prescribe it because it won't let you do that. And that can save serious reactions. So the program is trying to help the staff, and it's trying to communicate with patients. The patients have a choice of information in English or vernacular, and each institution can adjust the vernacular to their local language. We're all familiar with this way of distributing medication in sachets with ballpoint pen, but it's not always very clear, is it? It's not really clear. What does it mean, 1 times 3? The patient may not know what drug this is, what it's for. They don't understand. So STREAMLINE is producing a label which comes out every time and gives information in the language of the patient's choice. And we just use a receipt printer, which is the same as you would have when you go to a supermarket and they give you a receipt. It's the same printer, no ink required. And when we communicate with patients in their own language, this shows respect and it engages them in their care. Here's an example of a patient having TB being treated with rifampicin isoniazid. This message is warning the patient that their urine may turn red, orange red, and that this is normal. Now, if the patient had not received that information, what would they do? They might stop the treatment because they think they're bleeding, wouldn't they? And if they do that, the two things are going to happen. Number one, this patient will not improve. And number 2, we will see multi-resistant TB developing. So by putting this in so that every time our institution prescribes anybody rifampicin, this warning is given in the language the patient understands, we improve outcomes. We also have a link to the suspected adverse drug reaction link for the WHO, for the National Drug Authority of Uganda, to make it very easy to report. And that's important that we do that. STREAMLINE will also do real-time stock monitoring, and it also allows communication with prescribers. So here, for example, the prescriber is being told that an alternative drug is available in large quantity, and if clinically appropriate, would they please use it so that it doesn't run out on the shelf. Then prescription errors are really important. So first of all, STREAMLINE notes the name and phone number of the prescriber. On paper prescriptions, often the signatures are illegible, and the pharmacy have trouble knowing who's prescribed. Then if an error is made, the pharmacy will call the prescriber. If they agree to alter the prescription, they will then record what error was made, and they will grade it according to severity. This can then be reviewed on a prescription error report, which allows constructive feedback to the prescribers to try and avoid such problems in the future. There are a number of special templates. For example, in anesthesia, it encourages checking of the WHO safe surgery checklist. It uses a number of other safety scores which help to analyze how risky this patient is for anesthesia. On maternity, if a patient delivers on STREAMLINE, there's a two-way link created with the baby so that in the future, when the baby is growing up, we can go back to the mother's notes with one click. We have all sorts of reports in different specialties. This example is surgery. Allows us to interrogate. For example, we could look at all the cases done in a particular theatre if we have a problem with wound infections. We could look at all the cases done by a particular surgeon, and so on. And the system encourages safe handover, which is one of the most important things in medicine, isn't it? When we hand over as nurses or medical staff to our colleagues on the next roster, we need to make sure we communicate clearly so that things are smoothly handed over, and STREAMLINE assists in that. We also can create an inpatient attendant pass. This is to reduce the cross-infection risk of large numbers of people coming around the patient. So this can be used to reduce risk. The Lancet, about 1 month ago, had a very important article which talked about the previously under-recognized problem of childhood mortality after discharge from hospital. So in the 6 months after discharge from hospital, the mortality rates are the same as the mortality rates in the hospital. And so this has been looked at with the Smart Discharges program, and we've been able to link it into STREAMLINE, where a number of extra questions are asked to stratify the children according to risk. And if the child is found to have high risk on the algorithm, which is done automatically with that data, then it can lead to a report and an SMS text message to the village health teams to communicate that they need to follow up this child in the community. And it also causes more information to be given to the parents. And the pilot study, are you all awake? The pilot study on this demonstrated an extraordinary 30% reduction in mortality. And so building this in is something really important. And we're hoping that that's going to go out across some units. Finally, I'm going to finish on insurance, which started in Kisiki. It was the first community-based insurance scheme in the country. And the module on STREAMLINE supports it. We all know about the community groups. We've heard already about financing, but one thing you may not know is the health benefits. And this was a PhD study which showed again an extraordinary result, that the childhood stunting rates of families belonging to the scheme fell by more than 5% a year in those families compared with control families in the same communities. So a huge impact. And when we looked at the data on STREAMLINE for admission rates from our clinics, thinking there might be a bit of difference between patients on the scheme and patients not on the scheme, maybe there would be 5% or so. We were astonished. The difference was 50%. And this is universal health coverage in action, because what's happening is the insurance scheme patients are coming promptly because you've taken away a barrier. And that's a huge impact. And then we've also shown that it improves health promotion. So colleagues, I've shown you a few highlights of different ways that STREAMLINE impacts health and different ways that it reduces harm. Thank you for your attention. There are lots of different aspects that I haven't covered. Please look at the website. And remember, there's always a way to do things if you try hard enough. Thank you very much.
Thank you very much, Dr. Ian. Another hand clap for Dr. Ian Spielman. And thank you for that elaborate explanation and the linkages between STREAMLINE and community health financing. Ladies and gentlemen, we have been joined by the Senior Public Relations Officer of Ministry of Health, Mr. Emmanuel Aine Viona. Aine Viona means he has everything. I realized that Dr. Ian was translating in Ruchiga, but for some of you you were not following. And during the maybe lunchtime, you should be able to get some of the translations from him. So Emmanuel, you're welcome. Thank you for coming. Ian is a consultant pediatrician. Our next speaker is married to a consultant pediatrician. Please join with me to welcome Mr. Moses Mugume. Mr. Moses Mugume is the Principal Hospital Administrator, Church of Uganda, Chisizi Hospital, but he is also the Administrator of the Chisizi Community Health Insurance Scheme. He has both a master's degree in public health and a master's degree in business administration. He is a co-founder of Chisizi Community Health Insurance Scheme, and I first met him around 1998, 97, and I am saying that for a purpose, because you can see he's as pediatric as the person he's married or the person who deals with the children that they see. Join with me to welcome Moses Mugume.
Thank you so much, Dr. Kasiaba, for that kind introduction. Ladies and gentlemen, I will ride on the previous speaker's introduction by observing your presence. Ladies and gentlemen, it gives me joy to tell a story of health insurance. Chisizi Hospital was founded in 1958 by a young couple coming from the UK. They were missionaries. Because this part of Kigezi didn't have access to health care. And since then, it's been growing, but importantly, it has never closed its gates to people who seek to get help. In 1996, like any other health institution, Chisizi was struggling in terms of finances, but also in making sure that it would meet its vision of life in all its fullness. The hospital motto is entirely addressing issues of equity. We want every person to have access to health service. But that comes with its challenges. So basically for me, I'm going to tell the story of Kisizi and how the journey has been in making sure that we reduce barriers to people who would otherwise want to come to the hospital. Dr. Ian did mention that it started in 1996, but we were responding to some challenges. Professor did mention some of the barriers. A patient comes to the hospital, you give treatment, before they pay, they run away. And you don't have all the fence around the hospital to stop them. But also too, it would actually mean if they run away, you do not have funds to run the institution. But also you don't want to deny them a service. And this is why some hospitals would have stores for mattresses, for bicycles, simply because people have run away. It is indeed the oldest community health insurance in Uganda, and it has attracted a lot of attention in many areas. As mentioned before, the insurance was a response to following issues observed in the region. People dying when actually they are dying prematurely. If I come late, maybe I have complications, I may not survive. So we are responding to that. In the days of much malaria, people would first wait in the villages. I don't have the money, I have to go to a clinic, or I need to have a traditional healer, and therefore by the time I come to the hospital, it's late, and even the cost of treatment is going to be big, and that affects the resources of this person. Of course, we serve the rural poor. Some of you have been in Kisizi, you can be my witness that people's income is quite low. Peasant community, and therefore they struggle, and economics is quite a challenge. How then do you help them be able to pay money when they need a service? So we needed to do something. I talked about patients absconding. An attendant would come, take a few bags, and you see the patient maybe walking through the gate, and sometimes you notice when you see they had a cannula before, and therefore you might get to know that they're escaping. And why? How do you handle it? Because you are a church institution. Importantly, we are not for profit. If it was for profit, we probably would not have started even this health insurance. We aim at basically reaching a break-even, and that has got its attractive kind of attention. There are different schemes, but this one is hospital managed. What does it do? The communities collect money, send the money to the hospital up front, then you manage the fund yourself. That's the uniqueness about this Kisizi insurance. For the community to do that, they must be trusting you. Giving you money up front, and then you manage the fund, carries a lot of trust and faith in what you are doing as we continue to look at it. We are registered at the sub-county, but also we used to be a member of Health Financing Association. And the question to our panelists later is whether that legal framework is adequate. Is this adequate that I'm registered at the Gombora or sub-county? It's an area of discussion. Ian did mention some of the benefits being academic. A PhD student did actually indicate to us that stunted growth in members of the insurance in the children is very, very low. Now, this would be a typical meeting of the groups in the community. In Runyachitara, Runyankwe, Ruchiga, Ngozi is a stretcher actually. But basically, what we learned is that the communities that we serve have got structures of groups. What they do is that in case one person dies in a family, then the communities bring food. So the largest group would have about 160 people, and the smallest group would be around 20. But also we have observed that about 90% of the population that we serve, most of them would belong to such a groups. If we are not a member to Ngo's group, somehow you are a social misfit in the community. So they are well organized. Tradition, they exist to support with the funeral costs. So in 1996, that's when we entered into the community. Now, I was working with Tia Fund before, so Kisizi had a relationship with the community that was very good. So we took advantage of the existing structures and the fact that we had a good relationship, we started sensitizing people. But we are not expert in insurance. And when we talked about insurance, people got scared. Insurance then, I think, had a bad history. If you are going to claim for your money, it will take long or you will not get the money. And so they were saying, are you bringing this kind of insurance to us? So we had to work against that. Of course, when you drive through Kisizi, when you look at the published papers about Kisizi health insurance, you think it's fine. You think it will work everywhere. Professor Sengoba did mention about the context. And this is what I'm going to share with you, the challenges and how we've overcome them. When we had just started, prescribers or doctors in the clinic, once they got to know that we are a member of the insurance, they wrote all the medicines for you. And so we had to do not compromise the quality of the service, but be aware that you can actually waste the funds and the scheme will collapse. And so we had to sensitize our staff. Then we had an issue of I'm a member of insurance, therefore I can walk into the hospital anytime, even when I have a flu, even for medical checkups. And so we had to work on that by introducing a co-payment, and that helped. In 1997, there was a huge epidemic of malaria. I remember Uganda Red Cross came to Kisizi, we had tents outside in the compound, and the scheme lost a lot of money. And then the lesson was, do we then need to be reinsured? The hospital lost money. But in a way that brought good news in the fact that the community observed that even when they lost their money in the scheme, the hospital was liable. And that strengthened the relationship with the hospital. But also that meant we had to look at premium setting, and we were not experts. How do you set premiums when you are not an expert? We were thinking of crude figures. It worked for a short time, and we had this epidemic of malaria. And we got excited. Then we got an organization called Microcare. They came, they met with us, they wanted to partner with us. They had experts in insurance, they had experts in health economics, marketing, medicine. There was a gentleman called Dr. Jerry from Ireland. So we were like, wow, this is the right time. They did so well. They equipped the office, we did a lot of things, but in the course of the work, they collapsed. The organization became bankrupt and it was registered. So sometimes there are areas where you need to be good in screening, and Streamline for us now is the answer. Let's take advantage of the digital technology. Now, the other important thing to share with you is that we've learned over the years that community participation is important in decision making. For example, the structure, the way it's organized is that it's the chairman and treasurer to bring the money to the hospital. That's participation, but also it has got its risk. We've had incidences where money does not reach the hospital, but it's the community to address that problem. But for them, that's participation. Two, we have meetings with the community. You are talking over 200 groups that their chairmen come to annual general meeting, and therefore the hospital has got to give accountability. Transparency is important. We must read a statement of finances at the annual general meeting, and they ask questions. And so the institution as a service provider is accountable. But importantly, we also have a board, executive board. This is elected at the annual general meeting, and it's a liaison body with the hospital. They are the ones who come to the management and discuss issues of premiums, issues of challenges in the hospital, but also they participate in recruitment of the staff in the scheme, so they feel they are part of the system. But importantly, they are volunteers. Of course, you had challenges of also people wanting to join when they are sick, adverse selection, but we worked on that one. So these are some of the suggestions that we think can help, like suggesting a mobile wallet where the money shouldn't be physically delivered. But I was actually talking to the community, and they were saying, now, when you bring in that, the chairman didn't want to go to Kisizi, won't have an allowance for that day, then, so you have to be sensitive to the community how we do that. My presentation will come with questions to the experts in the area, and this is coming from the Kisizi experience. We've noticed that very poor, the poorest people, actually do not benefit from the scheme. So how do we address that, given that we are talking of universal coverage, given that we are talking of issues of equity? We have different packages for our beneficiaries. For example, now the community is saying, when I have a patient in Kisizi being referred to Mbarara Hospital, can you cover that? Can you cover the ambulance? If I'm a member of insurance of Kisizi, if I went to Nyachivari Hospital or Garama or Mbarara, I should be able to get the service. How do we then address that? Because it will make it more popular, but it comes with its challenges. Experts will help us in this. We are not experts in marketing, and therefore we need support in this area so that we are informed on the right things to do. We don't simply guess. One of the things we find difficult is setting premiums. Streamline has helped us in giving us data. We know the utilization trends, we know the money is involved, but can we extract that kind of information and help us to set premiums that are genuine? Of course, we do want to increase numbers, but I also don't want to get excited about numbers. The type of numbers you have does matter. What type of people do you have? If you have cases of chronic diseases only, then you end up with challenges. Let's see whether we can investigate reassurance for the hospital cover, like I did mention when you had epidemics. And also we have emerging infections. During the time of COVID, we had challenges. Even when we would want to refer people to cover referral hospital, they would tell you, I will die here, and they are members of insurance. They will consume all the money. Oxygen was quite expensive then. One thing I credit microcare was disease prevention. We are going to the communities, giving mosquito nets, giving health talks. And for us, we think if we invest in disease prevention, these schemes will survive. The screening process, let's take advantage of Streamline and digital technology. The fingerprints are being proposed. Now, these are happy children. I once went to sensitize the district council, the politicians, about health insurance. And the question was, what if I don't get sick? It's a challenge. I am healthy, why should I pay? I think we need to sensitize our communities, and we need a bit of input from experts. Because if a councillor at the district does ask you this, how about a woman in the village who is even never gone to school? So I'm coming to the last slide, but these are some of the lessons we've learned as Kisizi in our journey of health insurance. Trust in the service provider. If I go at 3 in the morning, will I find a doctor? If they prescribe medicine X, is it available? If I need a section in this hospital, are theater people available? A 24-hour service. 2, are you transparent with the money that we give you? The community must get involved so that we don't make decisions in the offices and not involve them. This is very important for us if we are to continue and sustain health insurance schemes. These boards are elected by the community, and most of them, surprisingly, 95% of them are retired teachers and headmasters. They are respected by the community. Let's take advantage of them, the leverage, in terms of who actually sits on the board and have a liaison function with the hospital leadership. The premiums must be affordable. And if you want them to be affordable, then you have to exclude some of the conditions, unfortunately. How do we then balance that? If the premiums are high, you may not be able to get people to enroll. The community is arranged in a unique way. The groups that we have, the network is good. The question then is, can this be duplicated in other places of the country? I don't know. Every place is unique and it must be in context. This is our constituents' character, because they have these Ngozi groups. They already do the pooling of funds together. So taking advantage of the system did help us. Our community is proud of their service provider. A sense of ownership. This is our hospital. If they see you as someone doing business, they may not participate in the scheme. This came in the waiting mother's home as a result of a mother who was brought to the hospital dead. You know, some studies have done about mothers waiting home, especially in places of Malawi and Zambia. So Kisisi has a mother's waiting home. We've also used it as a tool to sell, to attract market health insurance. When a mother is expecting, comes to Kisisi, you have a room, it's well furnished, you are looked after by the health workers until that time of delivering. Mothers like this, and it's free once you are a member of the insurance. You know, I'm 9 months, I still have to go and fetch water, collect firewood, the man comes home late, so you are free to be in the waiting mother at home. This has really marketed the insurance. Let's take advantage of the technology. I've mentioned that Kisisi has benefited. Let's do the financial literacy to the communities and the groups. But also importantly, let's be accountable as managers. From our journey of health insurance, policymakers, we need subsidies. If we are to address the issue of equity, the poorest will never join the schemes until you have subsidies, because the cost of running hospitals is quite high. Let's not put a lot of money in admin costs, administration. Our experience has shown that a smaller admin cost is helpful, but also have the people that you trust. And so, thank you.
Another hand clap for Mr. Moses Mugume. Thank you, Moses, for the nice presentation and a brief on Kisisi Community Health Insurance Scheme. Ladies and gentlemen, we have been joined by Dr. Charles Olaro. Dr. Charles Olaro is the Minister of Health Director for Curative Services. In case you may wish to strengthen the hand clap, in the Ministry of Health, the top-notch technical person is a Director General. In the Ministry of Health of Uganda, we have 4 directorates. So 3 directorates are filled. They have persons occupying them. And in our midst, we have one of the directors. So he's among the top-notch technical persons in the Ministry of Health. Would that encourage you to clap harder? So in effect, we have the Minister of Health with us. Dr. Olaro Charles, thank you for joining us. Dr. Charles Olaro also is a former executive director of the regional referrals from Arua across the whole country. But he's a senior consultant surgeon. So we've been hearing pediatricians, obstetricians. We now have a consultant surgeon. During lunchtime, they will be sharing their notes. Next to me here, we have a lady, Anne Malongo. Anne, that the network in this room is very good. But should you find yourself wanting to look for network outside this room, she can give you the directions.
Wazima together. Wazima together. Come on, we've just had something. Wazima together. More like it. From us to you, we hope you are so far feeling at Streamline. Wazima together. Great. Well, mine is simple. I'm just supposed to direct you, give you the house rules. If The rooms of convenience are just on my right. You will get out through any of those doors right at the extreme end. Thank you. Wazima together? Great.
Thank you very much, Anne. And please don't stigmatize those who go to look for network outside this room. You can take the other direction. I have been reminded from the presentations of Dr. Ian Spillman, Mr. Moses Mugume, and the ones that will follow, that there will be questions. They need to ask some clarifying questions. So we are going to have 2 brief presentations coming on, and thereafter I will announce to you the slight changes in the program that we are going to undertake. Since Mr. Idebiona is still briefing the director, because in case the director is called to give some remarks, he should not come and say, we grieve with the people who are going to be buried today. They should be knowing exactly what we are going to be talking about. So our next presentation is going to be a video conferencing presentation from Mr. Stefan Huber, who is a director at Swiss Reinsurance Foundation, and also sits on the board that gave the award for the program that we are launching today. Please join with me to welcome Stefan.
Warm welcome here from Zurich, Switzerland. Many thanks and a very warm welcome here from Zurich, Switzerland. Dear Permanent Secretary of the Ministry of Health, dear Diana Twine, dear members of the Parliament of Uganda, dear commissioners and senior staff, dear medical directors and staff members from partner hospitals and implementing partners of Streamline Health. It is truly my honor to be able to speak to you today about our work at the Swiss Re Foundation. My name is Stefan Huber and I am the director of Swiss Re Foundation. Let me briefly introduce our work and Swiss Re. Swiss Re is one of the world's leading providers of reinsurance, insurance and other forms of insurance-based risk transfer solutions, working to make the world more resilient. As its grant-making foundation, the Swiss Re Foundation reflects the social and humanitarian values of Swiss Re. Together with our Swiss Re employees and our partners such as NGOs, academia and social entrepreneurs, we support efforts to strengthen social resilience in countries where Swiss Re operates, but as well in targeted developing in emerging economies. As resilience is a comprehensive but as well complex concept, we are focusing all our activities on 2 focus areas. The first one is very much at the core of today's discussion. Our first focus area is access to health. Here we support solutions to increase financial access through insurance or saving wallets, for example, to large groups of people, as well as solutions that improve health systems efficiency in delivering care with respect to cost, impact and accessibility in remote areas. Our second area is natural hazard and climate risk management. Here we support partners that help communities in disaster-prone regions build their capacity to prevent and prepare for the impacts of natural catastrophe. Furthermore, we build local capacities and implement nature-based solutions in coastal areas. And one of the famous examples to illustrate this is our reef insurance model that we established in Mexico. You find more information on our webpage. And last but not least, we want to help as well smallholder farmers around the globe to adopt climate-friendly practices in a fastly changing environment. So that's what we do. Then we have established the Entrepreneurs for Resilience Award to raise awareness and stimulate discussions of challenges that communities face. We launched this flagship initiative back in 2016, and as the name indicates, the initiative recognizes entrepreneurial solutions that take innovative approaches to build resilient societies. It empowers local entrepreneurs in low-income countries developing their own solutions to improve lives of thousands of citizens in the regions. Our ambition is to make basic healthcare accessible and affordable to at least 1 million more people by 2024. Since 2021, we have dedicated the focus of our annual award program to the topic of increasing financial access to healthcare in low-income communities. Why? Just 3 years into the 2020s, the world has experienced two large-scale shock events, a global pandemic and now the war in the Ukraine. Both have significant consequences for the global economy and also immediate direct and indirect impacts on the level of income inequality. Low-income households have been hit disproportionately hard, leading to an increase in poverty rates. Though poverty is not always related to health, economists recognize that ill health is one of the biggest factors driving people into poverty. For this reason, most societies attempt to provide financial protection against catastrophic healthcare costs, most commonly through programs like public financing, private insurance, and charitable programs. While these forms of financial protection provide an important foundation for healthcare financing, they leave consistent gaps, causing individuals to bear a large proportion of their healthcare expenditure out of pocket. New approaches to financing healthcare are more urgently needed than ever. We are therefore convinced that social entrepreneurs like STREAMLINE Health can create positive change through new initiatives, particularly when it comes to the challenge of rural health financing, what we discussed today. By looking for new models and systems, they create social value and change people's life for the better. We believe that Swiss Re Foundation can make the most valuable contribution to partners like STREAMLINE Health and other social entrepreneurs in the early days, in the early stages of their development. Our funding therefore targets the development and testing of promising business models and the scale-up of impactful solutions. We are willing to de-risk high-risk early days of startups. With our Entrepreneurs for Resilience Award, the Foundation has supported 18 promising entrepreneurs so far across the globe and has awarded roughly $4 million to support these businesses. Beyond the financial support, it is an important part of our value proposition to offer as well access to expertise of the global company and leverage the global network to other donors, investors, and experts. STREAMLINE was chosen as our 2022 winner of the Entrepreneurs for Resilience Award out of 264 applications we had received from around the globe. The award jury has acknowledged that STREAMLINE is a pioneer in its focus on digitizing community-based and digitizing community-led healthcare-related savings schemes, and that its software is specifically designed for low resources contexts. It is easy to use and affordable and helps increasing the quality of healthcare provided. The global jury also acknowledged that the scale STREAMLINE has already reached and their very strong and dynamic team. STREAMLINE will use the award grant to support the establishment and expansion of community-based health insurance schemes across its 15 target hospitals and aims to reach a total of 200,000 people until 2024. We see a good fit for Swiss Re volunteers and experts to support STREAMLINE to improve their insurance-related capacities in-house. Swiss Re will help particularly in actuarial modeling and risk analysis. STREAMLINE will also benefit from Swiss Re's technology support to further develop the artificial intelligence components of its data analytics module and anti-fraud measures, such as biometric check of insurance scheme memberships. Ladies and gentlemen, with mounting threats to societal resilience, from pandemic to fragile economies and loss of biodiversity, climate change, we need to learn more from each other, and we need to integrate more. Therefore, we hope we all will be inspired and convinced by the important work that STREAMLINE is doing, and that you all will work together to contribute to closing the gap in health coverage.
Thank you very much for that clarification. So, ladies and gentlemen, we are remaining with one technical presentation before we go into the politics of the launch. And we have had 3 presentations so far. We could be having some questions for clarifications. We also have some clarifications and probably areas where we can have a little more perspective. So I'm now going to request my colleagues from STREAMLINE to come with their microphones. I think 3 or 4, 1, 2, 3, 4. And we can have questions for Dr. Ian, for Moses, and questions for Mr. Huber will be taken note of, and questions for the keynote speaker. When he was leaving, he asked Dr. Andrew Sechtoreko, the executive director of Nsambia Hospital, to take the questions and if need be, to pass them over. So, any questions, any clarifications while we await the last sessions of the presentation? Questions? Any clarifications?
Thank you. Thank you, Chair, and thank you by the previous discussants. My question goes to, maybe just before I ask my question, I just want to thank STREAMLINE, the entire team, and also the financials of this engagement. Clearly it shows you that this solution is a beneficiary of external financing. So that should actually trigger something to the policymakers in-house, why this should actually be inward-looking as well for years to come. But I just want to...
Is that a question you are directing to the director curative?
Don't worry. The responsible party has heard.
Okay.
Yes, yeah. So my question is the scale aspect of this solution. Now you've tested it.
At the time you introduce yourself.
Doctor, my name is Patrick Mugisha. I'm managing partner, Innovent Labs Africa, but former policymaker with the Ministry of Science, Technology and Innovation, Commissioner in charge of innovations and intellectual property management, now in the private sector. Thank you.
Thank you. Next, we have someone here. Okay.
Thank you, Doctor. And I thank whoever's presented before us, and everyone has been taking note of what has been shared. My concern is the beauty of the program and the scheme entirely. But my worry is about the perception of the individuals, particularly in this central region. The so-called central, we are not actually in the central, but particularly here in Uganda region, where people are so resilient to even things that are benefiting them.
Resilient or resistant?
Resistant. Yeah. Thank you for the correction. So, I'm wondering about the possible ways of how we are going to let the individuals in this region, possibly even other regions, how to adopt. Because we, the service providers, we are here readily available to provide the service and to help these people understand more about it. But and my appeal goes to the ministry and the policy makers.
The responsible people are taking questions. I hope when I say responses now, people will not say this was not directed to me because they didn't mention my name. Dr. Karegeya.
Thank you, Georgie. My question is, what is the cost implication? Because that really, in my view, determines how much people will be willing to adopt it and or sustain it for that matter. So what is the cost that comes with it? Thank you.
Thank you. Streamline, someone has taken note.
Thank you. My name is Alo Stephen. I'm a consultant with the Parliamentary Committee on Health, an economist. My question goes to Dr. Ian. How do you plan to incorporate Streamline platform into the government system? Is there a way you want to incorporate this to the public hospitals, especially the regional referral hospitals? Perfect. Then the second one goes to, what is the capacity of Streamline platform system to handle many users at the same time? Is it capable of handling so many thousand users at the same time? And then the last question it's related to his. What is the plan for the scale up of this project? Thank you.
Thank you. Then I think the last question in the corner there, and then we will have the responses.
Thank you. I'm Alon Musana from Mengo Hospital, and I work at the business development. I want to thank Streamline and all the participants. My question goes to Streamline. From your experience, where you have this system, what has been the biggest challenge? Because every system, somehow, somewhere, you can acknowledge and say, much as we have this product, our current challenge is this. And we need to be so sure so that we can also try to see how we contribute to it. Secondly, from the experience shared from Kisisi Hospital by Moses, you realize that Kisisi as a geographical area has its own uniqueness. And as for us people who are based in Kampala, it is the United States, where almost we have all the categories of Ugandans coming up. And we have the most stubborn users and consumers of health care, where you find that malpractice and impersonation is the order of the day. And also when you look at the intended objective of this community health insurance is to cater for this basic person in the community. But looking at the cost of healthcare in Kampala, it's very expensive. But again, you want to make it affordable. How can we have this solved? Thank you.
Thank you. I think we can have, okay.
Thank you so much, Doctor. I'm Edema Jime, Public Health Officer from Bishop Asili Hospital, and also the CHI Manager.
Your medical director came in still today, Dr.
Yes.
Dr. Charles Luanga. Dr. Charles Luanga, please stand up and people see the medical director of Bishop Asili. That is Dr. Charles Luanga. He's a consultant gynecologist.
Yes. My question I direct it to CZ, being that is our pioneer, especially in partnership with STREAMLINE. How have you used STREAMLINE, especially in onboarding members for the insurance scheme, and more importantly, in premium collection? How has STREAMLINE enhanced premium collection from members? And after collecting the premiums, how have you managed the premiums? The transaction, especially between the member and the hospital. Thank you.
Thank you very much, and that wraps up for the questions. Ladies and gentlemen, join with me to welcome the Honorable Frederick Ngobi Gume, the Minister of State for Trade, Industry and Cooperatives, a position he has held since 2016, and he's currently a Member of Parliament for Bulamoji Northwest County, and he has been an MP since 2016. The Ministry of Trade and Cooperatives, as I will explain to you, in this country, we have 15 health cooperatives which are registered with the Ministry of Trade. 8 of them are supported by Health Partners Uganda. Health cooperatives offer community health insurance mechanisms to members based on cooperative values and principles. And health cooperatives were...
Number one, you need to have trust in the provider so that you know that when you become sick at 3 o'clock in the morning, the provider will provide the service. Number two, we think that the not-for-profit basis has been one of the reasons it's worked, because the people know that our motivation is service and not profit, and that has helped it to grow. It has grown by reputation, so over the years it has now reached around 45,000 in about 200 community groups in 6 districts, up to about 50 kilometers from Kisisi. In terms of the other principle is community engagement that Moses also mentioned, that people have a sense of ownership and they want it to work. This helps it to be efficient, because otherwise things like fraudulent use can become an issue. Another issue on scaling up is to mention SACCOs. There's been quite a lot of dialogue with the national organisation of SACCOs, and Samuel may pick this up, but they're quite interested. These are genuine community groups, and they're already doing saving, and it's a logical extension to build it to the insurance scheme. In terms of number of users and capacity, I mean, I think it depends on the setup. Capacity can be provided as needed in the scale-up. The difference between Kisisi and Kampala, I'll let Moses pick up, and onboarding members. What was that one? Yeah. Oh yeah, I think on terms of the premiums, I think Moses, you could pick that one up. Thank you.
Okay, briefly, we are now going to be racing against time.
Thank you, moderator. The question about how STREAMLINE does benefit insurance. One of the issues is evidence medicine, because when you're using STREAMLINE, you are able to cite the protocols and things so you don't waste medicines and things. 2, STREAMLINE does generate reports, financial statements. If it's a click, and then I get reports how much money has been collected that day and how much has been paid as co-payment. It also gives information, utilization trends. I'm able to know the usage of service. But importantly, if I'm seated somewhere, I'm able to know the doctor who is working and who is not working. Room X have seen a few patients, the other one is 10. Where is the problem? Then it's able to inform me quickly that this person does not have the cover in terms of cover of insurance. But also if a member, the cover expires, I can quickly tell. So those are some of the benefits linked to the insurance. And for the, can we duplicate the XIS experience in other places? It's difficult because we have to look at each constituency, each place has got its own context. For example, you may not have Engos groups in Kampala. And this is what
childhood gastroenteritis, then targeted health promotion can go into that group. It improves their health. It also reduces the downstream costs. Thank you.
Thank you very much, Dr. Ian. So, ladies and gentlemen, we are going to have 3 speakers and we go to the launch. The first speaker will be the CEO of STREAMLINE, followed by the Director Curative Services, Dr. Charles Solaro, who will then invite the minister to give his remarks. After the remarks, we will go, the preparation for the launch is just out there. We will usher the minister, the director, and the senior leadership of STREAMLINE to the launch, where we shall have the launch of the program and thereafter have group photos, and I shall then usher you in for lunch. We still have the program ongoing. After lunch, we have a series of presentations and discussions, which I would encourage all of you to attend, particularly our political leadership, because this is where they get the meat to feed our people. May I now take this opportunity to invite Mr. Samuel Mugisha, the CEO and co-founder of STREAMLINE Health Company Limited. Samuel is a social serial entrepreneur who spent 12 years building and implementing technologies in the health sector in East Africa. This man has studied technology in Cyprus, in the UK, in the US, and I can say in the whole world. And that. But he previously worked as the head of software incubation and innovation at Mbarara University of Science and Technology. Please join with me to invite and welcome here Mr. Samuel Mugisha, who will give us an overview and will usher us into the launch program. Simon, you're welcome.
Thank you very much, MC. Introduces you everywhere. I think you would be very rich because he adds some spices to the introduction. Good afternoon. Yeah, I'm glad to be here today. And as we launch STREAMLINE Ubuntu today, I'm very happy to see all of you and to welcome you in this place. The slogan for today is, and maybe a bit so that we do this together. We'll do it again when we go to the launch. I know my friend Johnson here had introduced the sign Wazima like this, but we don't want to get into the politics of symbols and signs. So Wazima is, means healthy. Eh? So the slogan is healthy together. Healthy together. Are we together? Wazima together. So we are going to do it 3 times, and we all speak loudly as we stretch up and get ready for the launch. Wazima together. Wazima together. Wazima together. Fantastic. Let's repeat one more, because some people were still catching up, you know, getting to speed. Wazima. 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 Fantastic. You can clap for yourselves. Yeah, so very glad to meet all of you today. My name is Samuel Mugisha. I am the CEO at STREAMLINE Health, and I've spent the last 12 years really working in the health sector. And I remember the first time I made a decision to work in the health sector. We moved into a hospital, and then you just see problem after problem. Most of the hospitals, I think, are just problem centers. I met a lady in the queue, and the problem was, I'm very sick, but do you have some 5,000 that I could use for consultation? The doctors in the hospital are running around like headless chicken. It's mad. It's a very busy place. And I saw a niche, a space that needs our attention. The problems are really very, very big in our hospitals, and it's our duty to contribute to solving them. There is this very big problem that we have called BSD, borrow, sell, or die problem. And there is a report from the World Health Organization Universal Health Coverage Report that actually 30% of the households in Africa borrow to pay for health care. Your baby gets sick and you have to call friends and say, you know what, we are here at this hospital X, can you please bail me out? I'm expecting some money. Like we say here in Uganda, I will pay you at the end of the month. So borrowing, very huge debts. And it was this vicious cycle happens. And then the worst case is the dying. A 1.6 million die because they couldn't afford health care. You get sick, you don't have money, you try some herbs, you self-medicate. When it gets worse, you come in the hospital when it is too late. Again, research shows that. You come when it is too late, it has advanced, and you die. Or you just die at home because you couldn't afford. So those are the problems, very big problems, that Streamline Healthcare is trying to. Sandra Kahara, whom I met, a resident of Chisizi, in Kunjiri district in Uganda, 81 years old. In May 2019, she was diagnosed with uterine cancer. And there are many doctors in the room, you know what that means. Sandra's surgery required about 5 million Ugandan shillings. Last year, I think in November, when I visited her, and she's very happy, and happy as can be. So there is a huge success story that we encountered, the story at Chisizi. 25 years of giving health care to people like Sandra. 40,000 people in that community across 7 districts accessing health care from this hospital. Premiums as low as 18,000 per year. A normal delivery, if you are part of the insurance scheme, you pay your annual premium of 18,000, and then you would top up what we call a co-payment of 60,000, and you have a normal delivery. A surgical delivery goes for 200,000. Again, these are prices that are nowhere in the market. So a very wonderful model has been published about that and was featured in the Economist magazine. So we partnered with Chisizi Hospital since 2014, and we'll have learned a lot over the years, and learned also about this model. And we said, this model has worked. We want to scale it. We want to scale this model so that every mother, every old lady like Sandra can access health care. So we proposed a solution, which is the entire community health-based life cycle integrated in one package. Community health schemes, or what we would call actually community cooperative, health cooperatives, work with the basic principle of communities pooling resources together. By communities, we mean groups in the communities. These are women groups, these are schools, these are church groups, savings associations, whichever group. And the research shows that actually 90% of Ugandans belong to at least a group. Ugandans are very social people. They would belong to either a company, or a work association, or a burial group, or a Christmas saving group, whichever. People have different types of groups that they belong to. So we are saying that why not encourage these people to now begin to save for their health care? The collective energy, the collective pool is very strong. It's a principle that insurance has used over the years. That when people pool resources, the collective pool can actually treat all of them. Since some of them don't get sick, others get minor trusted hospitals. The partners that we are working with today who are here are all trusted hospitals. We make sure that communities are empowered, hospitals are empowered, and there is automation which builds trust, fraud is cut down, Everyone knows what is happening, and the process is easy for everyone. Yeah, so you heard from Stefan Huber. So we started looking for funding, because when you think of a project, it needs money to run. So we knocked on very many doors, and someone was asking, what does the Ugandan government done? Actually, the Ugandan government in 2015 gave us a grant through the Uganda National Council of Science and Technology. They gave us a grant of 160 million, which enabled us to do a pilot those days at Shiza and at Rugarama. So thanks to the Ugandan government. And we need more of that support these initiatives to move them across. Yeah, so we now knocked on the doors of Swiss Re Foundation, grant $350,000 to advance our work. And the project objectives are these. There are 3 objectives. 1, to extend access to affordable health care to more people. So through this project, we hope to extend this, what happened to Sandra, to more 150,000 people. So we are going to work with 15 hospital partners, and hopefully we are going to work together and extend affordable health care to more 150,000 people. And then we want to support hospitals and support their schemes to be sustainable. And we also want to bring in collaboration. The challenges we are talking about are very, very big. Alone, it would be simply a lie. We have to work with every one of you and very many people to solve these very big challenges. And really that is what our North Star is. We want families like these ones, who are the majority in Uganda, by the way. They according to the UBOS, the average, how much do you think is the average daily wage of a Ugandan? Average, someone wants to shout out, average daily wage. How much do you think a Ugandan on average earns per day, according to UBOS? Someone is Googling, really can afford health care for the people. The packages we are proposing, because of the mean daily wage that I have talked about, of begin accessing health care for acute and emergency conditions. We are also designing other packages for people who can afford more, and for some specialist groups like borders, like school children, etc. Also, each of these hospitals is going to get a lot of technology support. This is our strength. They are going to get a full electronic medical record platform. The STREAMLINE electronic medical platform was voted among the top 5 on the African continent by a World Bank group. We went for an interview, and we were interviewed by a team of experts, several, and they voted our platform among the top 5 under the Tech Image program. Details are online if you want to search them. Each of the hospitals will also get our scheme administration platform. They will get our community application. Mobile money. On top of that, they will get our business intelligence platform, the first of its kind. We are working with experts globally to build what we call business intelligence, the ability to forecast what is going to happen, to predict the future, and really work in a very, very sophisticated way. So each of these hospitals will get this technology support. A number of them, I think 8 of them already have full EMR. A number of them are already getting the scheme administration. They will get the community application, and they will all begin accessing business intelligence after this. And then we said it's not enough to just give them this. We must support them to do mobilization. Building a scheme or bringing together people takes a lot of effort. We will work with several partners to mobilize people. We are working with the UPMB, the UCMB. We are going to work with Airtel and MTN. The Uganda Circles Union Health Partners is here. Another NGO called Rural Inclusion. And we will work together to mobilize people, to let them know about this, to educate them, and to help them join groups. We will also give mobilization support. There are motorcycles at the back. Some of you would have been asking yourselves, what are these for? Each of the partner hospitals is going to get a motorcycle for the mobilizer when they are moving to these hard-to-reach communities. They will get a fueled motorcycle for a whole year. They will facilitate the person who will the mobilizer for whole 2 years. For a whole 2 years, they will get some radio airtime and a lot of also airtime for mobilization as part of the support to build community health schemes. We also give them some hardware, computer hardware in terms of fingerprint scanners for fraud management. They will get some barcode scanners and laminating machines to make cards which are identification cards. And they're also getting tablet phones for mobilizations as part of the package. So guest of honor, we look forward to a state at the end of 2 years where we will have helped 150,000 more people access affordable health care, where 15 schemes will be more powerful and more strong. To add to this, because we want to be very scientific in what we do, we have now secured funding to do a random control trial research, a huge research in partnership with Columbia University in USA, London School of Economics, and the University of Zurich. We are going to research on 8,000 households, very many households, and the random control trial, some of them will get a free package for a year, others will not get. And we want to study so much over the 2 years that we shall publish, and I think the ministry and everyone else will be glad to look at this, what we shall find out. What are the drivers to insurance? What are the benefits? How can it be scaled? What are the bottlenecks? It's going to be a random, it's a big research, $1 million funded. Ladies and gentlemen, I want to call us to join together and work on this big challenge. Like we have said today, Wazima together, healthy together. It's a big challenge, but we look forward to working with all of you to make a contribution to this challenge. Thank you very much.
Thank you, Samuel. You've been very elaborate, very clear. Ladies and gentlemen, this was the last technical presentation I would call. And I would like my co-MC to give you guidance on how we are going to do the launching process. And after my co-MC has given you the launching process, I will request you to stand and we shall have the anthems, because we have the member of the executive amongst us, and it is imperative that, the protocol, it is imperative on the protocol that we have the anthems for Uganda and for East Africa. Thereafter, I will invite Dr. Charles Solaro, who will then invite the minister. While Samuel was presenting, we were joined by Dr. Ronnie Bahatunjire, Atenyi Atwoki. Dr. Ronnie Bahatunjire is the Acting Commissioner for Clinical Services. I told you that we have 4 directorates in Ministry of Health. The director curative is here, and he's a director in charge of 4 departments. And one of the departments is the Department of Clinical, which is headed by the man seated to the director. Okay? So the other departments, they are not here. I will not talk about him. So he's at home with his director. May I request my co-MC to give us guidance on how we are going to proceed?
Thank you very much, sir. Your co-MCs are Simwe Lydia, the operations manager at STREAMLINE Health. So allow me to briefly take you through the proceedings of how our launch ceremony is going to be conducted. Our beloved Honorable Minister Frederick Ngobi, the Minister of Trade and Cooperatives, will be accompanied kindly by the guests who are sharing the table with him, the Director General, Clinical and Curative Services at Ministry of Health, Dr. Ronnie, the Acting Commissioner. You will kindly accompany the Minister, and then we'll together go behind this slide. We have prepared something. It is the STREAMLINE UBUNTU launch placard. So this is something we'll open the curtain, and the minister will append his signature to that placard as a sign that he has officially commissioned STREAMLINE UBUNTU and the project to revitalize rural health financing in Uganda. Then from here we shall gently walk with the Honorable to the place where our motorcycles have been assembled. Honorable Minister, we have 15 motorcycles that we are going to hand over to the first 15 partners we are working with on this project. Chiwoko Hospital of Nakaseke will receive a motorcycle, Kolonyi Hospital of Umbale District, Nkozi Hospital of Umpiji District, Villa Maria Hospital of Masaka District, Rugarama Hospital of Kabale District, Rushoroza Hospital of Kabale District, Mengo Hospital of Kampala, Bishop Caesar Asali of Luero District, Bethesda Hospital of Soroti, Ngora Frida Hospital of Ngora District, Gift Life Care Clinic of Lira District, Kagando Hospital of Kasese, Ruharo Mission Hospital of Mbarara District, Ishaka Adventist Hospital of Bushenyi District, and Chisizi Hospital of Rukunjiri District. The partners will assemble with the Honorable, and we shall take some pictures as they receive these motorcycles to go and mobilize the communities. Then finally, we shall walk to the photo booth, which is outside. The press will be assembled there. All our photographers will be there. We shall take a kind photograph with our guests, our beloved guests, and all partners at the photo booth. And then we will proceed for lunch. This is how the proceeding will be. Please, we also have souvenirs that we will give to every guest that has come to this launch event. So the honorables their souvenirs will be presented to them right immediately after the photos. I hope that briefs it. Yes, thank you.
Thank you very much. Of course, when all these eyes are looking at you, and the director is not about to retire, and the commissioner is also seated next to him, and you pronounce them in the same word, one might think that you are intending something which is not intended. But I can assure you, some of these borders may not reach Kabale when they ride them, unless you change 2T oil in Masaka. And I can also assure you that Dr. Crescent cannot ride a motorcycle from Nkozi to... So, let's all stand, and we have the anthems. We will begin with the Ugandan national anthem, followed by the East African national anthem, and immediately thereafter, Dr. Charles Olaro will come here to give his remarks.
Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike, umoja wetu ni nguzo yetu.
Thank you. May you all take your seats. I'll now take this honor to invite the Director Curative Services, Dr. Charles Olaro. I was going to complain, since I'm about to retire from being an MC and the hand claps seem to be not going well, I was going to get worried. Charles, you're welcome.
Thank you, Dr. Kasiaba. The Honorable Minister of State for Trade and Cooperatives, Honorable Frederick Ngovi Guma, the Chief Executive officer of STREAMLINE, my colleague, the Acting Commissioner, Clinical Services, all the partners of STREAMLINE in your respective capacities, ladies and gentlemen. It's a pleasure to join you when we are discussing this very important subject of revitalizing rural health financing in Uganda. And as all of you are aware that though urbanization has taken place, but the majority of our people still live in the rural areas. So if there is any investment, then we have to do that. We also cognizant that in Uganda, we still have a high out-of-pocket expenditure in health, almost the out-of-pocket contributing to about 38%. The figures vary depending on who has done the research. And also there's a consensus, I think that everybody in this room and even out there, that we need some form of insurance, such kind of social protection. And I think there's nobody who knows this better than the Minister of Trade and Cooperatives, that we really need this. As has been highlighted, it's no longer that when COVID came, the COVID experience showed us that there was nobody who was immune to this catastrophic expenditure. So whether we are rich or poor, but definitely the more vulnerable are much more affected than one. So we need insurance. Government definitely has come with a parish development model, which we hope that it will be able to reduce poverty and increase households to be able to contribute. Because as you heard that, poor health pushes people to poverty. So I think, Honorable Minister, we have to be able to see that we integrate health as part of the, I know it's one of the pillars in service delivery, to be able to see that we handle ill health, because if people are healthy, then because if not, then they will not be able to increase their household income. And they will be able to spend more and more of them will be pushed into what? Poverty. I was not here when the guest speaker was here, but I think based on what the Chief Executive Officer has highlighted, I think he gave in a vivid picture where how you get into this vicious circle. And also the last case you saw where the lady had the two options, whether to sell the land and then live in poverty or to die. And those are sometimes options which are very, very difficult. So we need to embrace, definitely as we address health issue, we need to be able to embrace poverty alleviation. We need to be able to embrace the parish development model as really one of the drivers where we should be able to do that, because all of them, so that even if we want people to contribute certain premium, they should be able to have household income. We should be able to do that. The existing community health insurance initiatives, Honorable, provides us an experience. As you are aware that government has been in the process of introducing the national health insurance. So if you see the one of Kisisi, it has been 25 years. So we don't need to go out of the country to benchmark anywhere. Only what you need to drive is drive to Kisisi, and you'll be able to do what? To be able to learn from there. And I'm sure now that with the value addition from STREAMLINE, all the innovation, the digitalization, everything, it's there because people have cards and you'll be able to do what? And as you see that people are able to move with the fraud what? Biometrics, to be able to see that this is the actual person who is registered and who will be able to So I think that as we move towards the national insurance, we should be able to learn from the community health insurance, and so that we can be able to build a formidable system for this country. All of you know that consensus that the strongest catalyst for achieving universal coverage is by adequately financing health in an innovative pool of resources for the prepaid health care. So we really need to be able that people contribute when they are healthy, most times, the time when you fall sick is actually when the money is what? Not there. You have the money when you are not, when you are healthy, but when you are sick, the money is what? Not there. So people should be able to contribute when they are healthy. But also it's giving us a framework that is actually possible for everybody, so that we do not have issues that there's nobody who cannot contribute. Because when you are looking at here, the small premiums which people can be able to do what? Make the small contributions. Then you can tailor it based on the people's income. So one of it is definitely you have to have that catalytic achieving universal coverage by adequately financing it. So we need to be able to have these innovative ways of collecting it. So universal health coverage progress depends on extending coverage to more people. And as you've heard, this will be able to extend to about 150,000 people. It's a small number, but it's significant, because even one person, that's a very significant number. So we're really looking at that. This is a good method that we can be able to expand. And I'm sure that from the time we finish the 3 years, and the numbers will be able to grow, because depending on the experience which people have, that's when you can be able to mobilize other people. So we need to extend coverage. We also need to be able to provision of priority services, because there are key services, key packages which we need to look at what people need. You can't do without a Caesar. You can't do without normal delivery. You can't do without having a child who will come with either with malaria or others. So those are the priority services which we need to be able to avail there. What we need only to repackage is that we need to be able to see how much are we addressing with the prevention, because we wouldn't really want to continue people to keep coming to consume their premium, because they are small premiums. But we really would want that, as was highlighted by the ED of Kisisi, from the data, you should be able to identify what is coming from the community and be able to address it, so that you close the gap, so that you don't have children coming with diarrhea. You need to be able to address aspects of that. All the children are immunized, and there are no zero-dose children in those communities where probably there's a risk of outbreaks. The other one is pulling up resources to avoid dangerous situations for waiting when you are sick. I think this one I've mentioned. So we're really looking at that. We need to be able to see how efficiently, equitable, accessible, and at the same time affordable we are able to do this, and definitely at the same time provide quality of health care. So the bottom is quality, because even if you are looking at any person needs quality of care. So I want to thank Streamline Ubuntu for coming up with this initiative, and really for putting this proposal, which has been able to pull these resources to United States $350. So I think we need to applaud them. And we need to tell them again that we do not need to wait until when we have finished to use the 350. We need to be looking for other resources to be able to do that. So as they have highlighted, they are expanding to 15 hospitals across the country. I think this will give really a good representation, and also will be able to show us what's the acceptability of what we want. To extend access to affordable care, facilitate hospital and community schemes, but also provide for collaborations and research. Because that's normally how we fail, because I'm looking at that from the implementation research. We can be able to see what are the things which we need to be able to correct, where we probably were doing very well and need to scale them. So I think we will be able to look at that, and working with the University of Zurich and Columbia. And I hope also that we shall also build capacity to work with local universities, so that it's one way of sustainability, so that we do not need to look at foreign most of the time. So as I conclude, I want to end up by saying that the Ministry of Health has finalized the final consultation for the National Health Insurance, and the Minister is soon due to represent it to Cabinet, and if Cabinet finalizes this, then to Parliament, and I'm sure that when it's done, then we should be able to look at that. So I want once again to thank the organizers of this, that this is a great innovation, great learning, and also great opportunity for our country to be able to see that we need an insurance. As Uganda, as the people of Uganda, Honorable Minister, one of the things I think we need is health insurance. So I think with those few remarks, ladies and gentlemen, it's my pleasure to invite the Honorable Minister, Honorable Frederick Guba, to address us, and if we could be clap for him so as he comes.
Thank you very much. Doctor, I am now confused. Curative, preventive, or all of you? The Chief Executive Officer of Streamline, UBUNTU, and our development partners, doctors here present, and all of you participants, ladies and gentlemen, I'm very excited to be here with you this afternoon, especially to launch this very important innovation that has come to the country. And I hope, for me when I was seated here, I was attracted to one word, Ubuntu. Some of you may take it in passing, but in our country, the word Ubuntu has so many implications. The Baganda would say, "Nawe bera mwako Ubuntu." Ubuntu. Togetherness and in trust is precisely the definition, a personal definition that I can attach to Ubuntu. It is an aspect of collectiveness. And like the previous speakers mentioned, they are surprised that the Minister for Cooperatives is here. I would like to inform you, especially you doctors and health practitioners, because more often than not, when you come from home, you're in the hospital talking to patients. And from there, you go for your research and go home. It is a routine. But I would like to inform you that people now have become very innovative to fight poverty and many other problems. They have become innovative by coming together. I would like to give you one small story of some early time when really people wanted to eat mere meat before the domestication of animals. A man was thirsty for meat. Those early days. But he couldn't get any animal or any type of meat because they did not domesticated the animals. But they wanted to eat meat. So what did they do? He called the colleagues. You know, they would blow a trumpet or a bugle. They came together and said, we must look for meat. Now decided to look for meat where they were not sure whether they would get meat. But they had dogs which would sniff and maybe give some symbolic presence of meat. So as they were going, there were 6 with their spears. On their way, they found 3 lions. The 3 lions were busy feasting on an animal they had captured and killed. So now they hesitated. What next? Do we attack the lions and take the meat? Because the lions had just eaten half. They thought a lot until they decided that let what come may. Let's go for the lions. 3 lions, 6 people. What do? They continued moving towards the lions. And the lions were amazed at people following them. These people, the leader of the group told them, let's continue. The lions had never seen courageous people approaching them. So you know what eventually the lions did? They took off. They took off about 400 meters to really find out what was happening. So courageously, the hunters went, grabbed the meat, part of it, of course they couldn't lift the whole of it, and started going away. So that approach satisfied their hunger. The hunger was reduced, the hunger for meat, through courage. That is why in our language they say, obwavu mpologoma, cynically meaning, boterwa na kekuta. If, even the African belief is, when you find a lion, you go straight. The moment you show it your back, it will be eaten up. So that is the first area of collective, not bargaining, but collective efforts to have meat. That is coming together. Currently, the country, 90% of the population is involved in working together in groups. Saving is the most important. But some of you who maybe grew up from here know very well that those days around Christmas, people would organize families and bring food together and eat. That was also Ubuntu, coming together. And when you are together, you can learn how the other person prepares a meal. So they would eat from this home, go to the other for a very long time. Many cooperatives in essence have come up. We have housing cooperatives, people that address the needs of their housing problems. We have energy cooperatives, we have the common circles, we have farmers cooperatives. Now, we also have a number of health cooperatives. And I'm glad to be here and associate myself to the STREAMLINE Ubuntu program. What happens? I felt touched. You either borrow, they mentioned it here, sell or die. Suffice it to note that everybody wants to live longer. And everybody enjoys a healthy status at a certain time. But the problem is, people think they'll never fall sick. And people think that when you're healthy, you'll be healthy throughout your time. Now, I am an example here. I used to play plenty of football. Now, as I deteriorate in age, I can't run 400 meters like I used to run 2,000 shillings. That's why we are here. I want to thank the donors and your initiation for this program. But I would also like to inform you that the doctors, I was a district chairperson in Ginya one time, and I had a doctor, the health inspector. The district health inspector was Dr. Chitimbo. So we were approving a budget. And in the budget, he had put a lot of money for. So as a chairperson, I said, no, this money that you have put in training is a lot. You had better put it in the purchase of drugs. Now, this doctor was very intelligent, and he knew that I did some economics. You know what he told me? That, Chairman, the square root of 49 has been 7 since you were born. I said, yes. But medicine and diseases change with time. They emulate. We are treating malaria with a certain drug. Now we need to treat malaria because it has changed its status with a different drug. So the more need, we should have money for training. Now, this program itself is enough for researchers, you scientists. It is enough to guide the government also. Because if people are in if people are in an insurance group, you will know the prevalent disease in a certain region. And it will also inform government. As we supply medicine to various hospitals, we will know that malaria is very prevalent in the north and dysentery is very prevalent in the west. That is also an opportunity for you to keep records, and also government should be able to learn from you on how to approach its supply. But also the issue of preventive care. It is an opportunity when people are together, you can be able to disseminate information to a very big group in a very limited time. We have guidelines. We have guidelines that surround the cooperators. In cooperatives, like you've equally said it here, we don't make profits. In cooperatives, we save. Businessmen make profits. For us, we make savings for the future and also carry out social corporate responsibilities. So I would like to encourage you, and I'm actually very taken up by this program, and would like to request that as you move, you disseminate and decentralize this program, please take it further to the ground. Alongside the parish development model, it is an opportunity. The parish development model is an approach that has brought the whole of the government to the parish. We have transferred the whole of government programs at the parish level. Financial inclusion, health as one of the pillars, infrastructure. So, while we are giving people money to assist them develop themselves, we also now going to add in this aspect, save for your future. And it will also save many lives, and will be able to witness a developed nation, as we also wait for the Ministry of Health to bring the health insurance package to cabinet. The issue of accountability. This money is from the common people. You know, when somebody gets 2,000 and puts it in a pool, you had better protect it very well, because it is all that he has to save for his life. But I'm happy you have procedures, you have interventions that are going to assist you. And I want to thank you for inviting me here, and I want also to inform you that you have my support, especially where you touch the cooperatives. You have my support. We want people to come together. When they come together, they are very strong and they have a voice. And as such, we are able to come in. I want to thank you. I would have been here early in the morning, but at least I'm happy that I've caught up the real gist of this program. Thank you very much, and would like to thank our donors for the $350,000. And quite often, than not, we behave like Oliver Twist, that as we move, we would request for more. But even these savings are going to be a very, very big resource that can assist our people in this country. I want to thank you for the opportunity given to me. I don't know whether this is the time for launching or just a submission of my speech and then sign, and then we'll have another launching program. MC, I therefore wish to take this singular honor to launch the STREAMLINE UBUNTU program aimed at revitalizing rural health financing in 2023 for God and my country.
A big hand clap, a big hand clap to our guest. Thank you so much, Honorable. Without wasting time, let's go ahead, Honorable, and we sign the STREAMLINE launch placard. Please, members, partners, join us as the Honorable Minister draws the curtain to append his signature. Dr. Ian Spielman, the team of Chisizi, a partner representative, at least our guests invited, please join us. Dr. Kenya, you are invited to come here. Jackie, please draw this curtain. He's the one to draw it. Honorable Minister, you're the one to draw the curtain. Yes. Please, let's assemble the camera crew. We do have fireworks, Honorable Minister, but it's very safe. It has been tested, it's very safe. Yes. Yes, please draw the curtain. Jackie, we can lay it down, it's okay. Yes. A big hand clap. A big, big hand clap. Congratulations, Streamline Ubuntu, launched today, the 22nd of February, 2023. Congratulations to our partners, to the communities that are going to benefit from this program. Congratulations. Thank you, Honorable. Thank you so much. This placard is going to be framed and hanged at our service centers. Please, if we could, Mr. Kaseab, are you saying something? Yes, Dr. Olaro is going to sign as well. A big hand clap for the doctor. Congratulations. Thank you so much. Yes, we still have one more signature coming. Please, please. Dr. Ronnie's signature is coming on board. Thank you so much, Dr. Ronnie. A big hand clap, ladies and gentlemen. Yes. Thank you so much. In the interest of time, whoever would like to sign on this board is free to come, get a marker and sign. But for now, let's move forward with the Honorable Minister and we go to the motorcycles area. Our dear partners, please come with us. And we accompany the Honorable Minister. The purpose of these motorcycles, Honorable, is to support community engagement as we move from our health facilities to the communities. We want quick means, quick means. Let's have one partner represent the other partners and take part, yes. And yes. Madam Lydia from Ishaka Adventist Hospital, Maureen Ruharo, Mission Hospital, we are all here. Thank you so much. Please smile as we take this photo. Thank you so much. Camera crew, let me know when this is done and we move to the next stage. Thank you, Honorable Minister, for handing over these motorcycles officially to the partners. We really appreciate it. Please create a way here and we move to the photo booth.
And please be sure to receive a receipt for lunch, a coupon for lunch. It will be handed to you at the entry, at the exit. Put it in the pocket and have a photo.
We are all invited to the photo booth. Kindly, all of us, let us stand next to the Honorable Minister and we all take a photograph with him. All of us, kindly, let's convene at the photo booth. Our dear guests, the Streamline team, our dear partners, the press is waiting for us, our camera crew is there.
Thank you very much, you who is watching us live on Creative Digital Media. We are very glad that you are actually following us live, and of course, always grateful for the support that you render us, and we all can only pray that that actually continues as we embark on growth of this journey that we have actually started in the recent past. Yes, thank you very much. And the event you're watching is actually the launch of Streamline Ubuntu. And very many people, of course, have already spoken about it. Quite a number of good, I would say diction that people are choosing to use with this very innovation. And trust me, of course, it is timely. Most of them linking it to post-COVID-19, most of them linking it to poverty, most of them linking it to medical care being, unaffordable, and all those. Of course, you would say there's no doubt about that. This innovation is actually going way, way, way beyond. Now, you may want to interest yourself in knowing what could be next after, of course, having, listened from the person that was, launching this very one, Honorable Minister Charles, putting it clear that he is actually pledging full support of government for such initiatives. And that goes without saying, of course, that Streamline in itself has actually already, attracted a number of funding opportunities. I think the most notable one being the one from the Swiss Foundation, around 350,000 US dollars coming in to support the innovation and making sure that rural health financing is actually vitalized. Quite a number of them, of course, but also in his own words, the director or founder or CEO, Comrade Samuel Mugesha, put it that actually previously the government had, supported them with a tone of around 150 plus million, to at least get into different hospitals and health centers. Now, to remind you, of course, is that the innovation has not actually just started. Started with normal systems that one would actually quickly think of, especially in the line of tech. Someone is going to quickly think of a hospital management system, a pharmacy kind of management system, a clinic management of system. And I would comfortably say that Streamline actually could have had its journey start just like that, but the moment, they hit the rural touch of that, to be specific, Chisizi Hospital, that was the, breakthrough. And finally, we got to be actually here to launch another game changer within the health sector of Uganda. Quite notable ones, of course, to tell you that this have already been talked about. The innovation, again, looks at how someone is actually going to, quickly or easily afford medical bills here and there. And trust me, it is always going to be a very, very, very innovative kind of touch that you want to attribute to this very, very great team. What do you have to say about this very launch? You could still go ahead and drop your comment in there. I saw quite a number of them, congratulating the team, and that is always very, very important. And trust me, we will be able to, again, continue with you till the close of the day. Maybe to give you a snippet of what is actually going to be happening within this afternoon, something that you may actually not want to miss. You may not want to actually run away, because slightly after lunch, we expect to have a panel discussion, which is actually scheduled to start at 2:30 p.m. with generally a focus, the discussion focus being the road to universal health coverage and health financing, challenges, opportunities, and enablers. This could be a very wonderful talk for you who is actually thinking that you have, minds or plans of finding yourself in any of these sectors. We are talking about universal health coverage and health financing. In case you are planning to, venture in these areas, then this could be your area, because this panel is actually going to be discussing the challenges, opportunities, and actually the enablers within the very sector. Of course, we understand that ICT remains a key enabler when it comes to such. That's why you see Ubuntu gets to be launched today. Now, but that, of course, doesn't mean that all problems within the very sector have actually all been addressed. This could be your chance to actually, explore the opportunity. Now, don't seize the moment, please. Go ahead and make sure you actually don't miss this very, very, panel discussion. Now, the discussion is actually going to have quite a number of people. If we remember Moses Mugume, who is actually the founder of Kisi's Community Health Insurance back in Rukunjiri, he is actually going to be, moderating this very one. The gentleman, of course, with quite a number of experience in the rural setup when it comes back to medical setup. Now, he will be joined by Dr. Andrew Sechitoleko, who is a medical director at Nsambya Hospital, but also Johnson Andinda, who is a program manager at the Health Partners. And if we could also remind you that Dr. Gerard Karejea is actually going to be joining the same panel, and you don't have to miss that. Dr. Gerard Karejea is the financing team lead, who is actually also the USAID UHSS project there. Of course, yes, head financing team lead at the USAID UHSS project. Then we also have Dr. Patrick Kachan, who is manager health systems strengthening. That is UPMB. And you actually don't want to miss that. Now, later after that, we will be having another, wonderful panel that you may not actually want to equally miss. In case you've been planning to, kind yourself interested in the role of technology in improving access to affordable health care. Now, this is another important area that you may actually not want to actually miss out. Role of technology in improving access to affordable health care is another great chance for you who has interest in actually joining this very, very sector. We will be having that session again chaired by Comrade Moses Wawelu, who is a senior program manager at Vilgro Africa. Vilgro Africa is actually another very, big funder within tech innovations. In case you're planning to have a tech innovation, then you want to actually understand that Vilgro Africa is your next stop. You need to actually interact with that very one. Now, Moses Wawelu, who is from there, who is actually also a senior program manager, will be chairing this panel with, of course, panelists like Paul Mbaka, who is the head division of health information at Ministry of Health of Uganda, but also Dr. Solomon Kamurari, who is a program manager at the Uganda UK Health Alliance, and also Wens Bender, who is the IT USAID UHSS, and also Patrick Joram Mugisha, who actually already told us that he prefers to be, referred to as Mugi. Will also be joining the panel. Patrick here, or Mugi, is actually managing partner of Innovent Labs Africa. He earlier told us that he was actually formerly within the Ministry of, was it Science and Technology, something like that, a PS there. But we also have Faizo Lubega, who is a CTO at Streamline Health, is also actually going to be joining the panel. So both panels actually talk to you who has interest in having ICT drive the kind of healthcare. Now, standing next, of course, the launch pad where this very one has been actually launched, and trust me, this has been the core of the event, and we actually already saw the Minister of State Minister for Trade, Industry and Cooperatives launching this, and trust me, joined by very many others. And you may want to interest yourself in knowing a little bit more about Streamline Ubuntu. You may want to visit www.streamhealthtech.com. That is, you're going to be getting actually more kind of details there. But yes, it goes with a tagline: Wazima Together, health plans starting at Uganda shillings 2,000 per month, and that actually means that you could save just 2,000 per month, and you're sure that you will be actually kind of securing the future of your medical care. You don't know what would actually happen at any time, and that is always very, very important aspect within that within your life that you may want to actually consider here and there. Now, I could be able to try to reach out to a few members, I believe, could be part of the Streamline team to have here and there. You don't to miss, in case the making of Streamline Ubuntu is another important bit of it. In a few minutes, I think I will be able to access Comrade Faizo to summarize for us just the journey in a few seconds. Don't worry. Of course, so you will be able to also get the snippet of what will be happening in the afternoon. All proceedings, of course, live on Creative Media, to remind you that in case you have an event and you actually want it live, then you should be able to actually link with us. Comrade Faizo, sorry for hijacking you. I understand you will be joining the panel in the afternoon, but we have a community that is actually watching us live online while you went for lunch. Of course, they stayed on watching, and I just promised them that we will be able to hear from you the making of Streamline Ubuntu, if you could be able to summarize it within your words. First, anyway, you could actually be able to tell them the role at the Streamline team. Thank you very much.
Thank you. I'm called Faisal Vega, and I'm the CTO at Streamline Health Tech Company Limited. I'm glad to meet our online community, and thank you so much for being with us since we started, and we hope you've been following and enjoyed the session. Streamline Ubuntu basically is a project that is helping hospitals and the community to bring them together to help the person at the bottom of the pyramid access affordable healthcare at the lowest cost possible. So at Streamline, we are providing technology to enable hospitals organize their systems, but also enable hospitals run and manage community health schemes, which can now help people at the bottom of the pyramid access affordable health care, help them stop from incurring catastrophic, you can call it out of the pocket costs. As you know, most of the times for people in the villages especially, when they have family members who are sick, usually they have three options. Yes. Either you're going to borrow money from a colleague, which you're not so sure whether they have, or you're going to sell any property you have, a cow, a goat, your land, your chibanja.
We are going to sell
exactly.
land.
Or sometimes what you do, you say, okay, there's nothing I can do now, whatever happens. So you wait to die. You've seen some of those challenges. None of those are really, really feasible and practical. Therefore, at Streamline, we are enabling hospitals to mobilize communities and form community health schemes and save a small fee out of the little they earn so that they can then be able to access affordable and quality health care anytime any of their members get sick at a preferred partner hospital, especially the non-for-profit hospitals that are also working hard to make sure that they can provide affordable quality health care.
Okay.
Yeah.
Finally, okay.
Yeah.
Well, finally, sorry about that. Yes. We will be able to get Faizo in the next few seconds from now. We will be discussing the uptake of technology. We understand is a major another key, challenge over there. But in case you kind of have anything to pass to the team, then you may need to actually pass it around. Could you drop a comment there that you may want to have read before the Streamline team? I don't know. You could be able to actually drop it around, and we will be able to actually get it reach the Streamline team. Preferable, of course, is that within the panel discussions that are going to be taking place, in case you have any kind of feedback, in case you have any, we will be able to reach it to the panelists, because that time is not for speeches, that time is for opinions, and opinions can always be, queried, and you can always seek clarification from them. You can always give, contribution. So within the afternoon, please don't actually dare miss this very opportunity, and trust me, you may want to not run away. We will be, cutting it shortly here for a break at lunch, and trust me, we will be resuming this immediately after lunch time. Please don't dare go away.
To the panel discussions. Ladies and gentlemen, we are going into a session of panel discussions. I am going to call upon some delegates who are also experts in their field, and they will be taking us through certain topics and discussions, and we shall be free to ask questions and also participate in the discussion. This is going to take a very short time. The first panel will take maybe not more than, Mr. Mugume, I don't know, in the interest of time, I think we could cover everything within an... You think we could be done with the discussion by 3:30? So that we have some time for Q&A, and then we invite the next panel for another maybe 30 minutes. We should be comfortably able to leave this place latest 5 p.m. Ladies and gentlemen, without wasting your time, the first panel discussion is going to be led by Mr. Moses Mugume, the founder, one of the founders of the Kisizi Community Health Insurance. Please come forward, Mr. Moses Mugume. Let us receive him with a big hand clap. He already gave his speech here, and now he's going to lead us in a discussion of the topic that reads Road to Universal Health Coverage and Health Financing. We are going to look at challenges and enablers. Please welcome him once again. Mr. Mugume will deal with a team of panelists whom I'm going to read, and as I read the members, please gracefully walk forward and join Mr. Mugume on the platform. Dr. Andrew Sechtoreko, the medical director at Nsambya Hospital. You're welcome. Please, let's welcome him. Let's welcome Mr. Johnson Andinda, the program manager of Health Partners. Please welcome him. Let's welcome Dr. Gerald Karejeya, Health Financing Team Lead, USAID UHSS Project. Please welcome him. Join me also finally, last but not least, to welcome Dr. Patrick Kaichan, Manager Health Systems Strengthening UPMB. Forgive me if I have mispronounced the name. We will give you an opportunity to briefly introduce yourselves since we don't have the profiles written down. Over to you, Mr. Mugume.
Thank you so much for that introduction. Ladies and gentlemen, who come back from lunch. We do not have much time, but let me touch a bit of profile for our panelists. They are all very able people. We have categories of people who have been in management of the hospitals, but also some academicians. So, Dr. Sechtoreko, you may want to add on your profile, but let me say he is managing a huge institution and he's got very good experience. And please listen to him, learn from him. We also have Johnson. He's got experience in leading us and guiding us in opportunities we have in alternative health financing. So listen to him. Dr. Gerard, he's had work to support the government in different areas. He's got a huge CV, very impressive. And please listen to him for what we are going to learn from him. Patrick has had time at UPMB, but also was a medical superintendent for a long time. So he's had that kind of wide experience, and we are looking forward to the discussion and how you contribute to the journey of health insurance and alternative health financing. We have a few questions, but I wanted to direct them to different people. And the first question we have, the audience will be coming in later, is to people who have been in positions of leadership. And I want to ask about the challenges you have had in your organization, challenges you've encountered in trying to provide affordable health care to the vulnerable and the rest of the population. Other panelists are free to contribute, but let the lead person this be Dr. Sechtoreko. Is that fine?
Thank you very much, and good afternoon. Wazima together. All right, so I've been asked to discuss the challenges we face as providers of health care in trying to deliver affordable care to those that are vulnerable. And I attempt this by saying that the first thing is that the cost of health care is not reducing at all. It actually is growing. The cost of delivering health care, or the cost of doing business in healthcare. The taxman is not taking it easy on institutions. While some of us are private, not for profit, but there's a lot within the tax bracket that we've become susceptible, and we have to pay tax. But then also healthcare has to be delivered a lot by expensive technology. some of it is equipment. Most of you now know that every hospital must have a CT scan. We talk about it simply, but you know, most of us drive cars, a Mercedes-Benz ML class. Probably the most expensive car driven in this room could get me, or 3 of your cars get me 1 CT scan. Now, to maintain that piece of equipment that is that expensive needs high-tech engineers, and just keeping it working is costly. We have MRIs. Some of you know this technology. MRI technology should never go off power at all. Never. You're not allowed to have any drop in power. But think of Uganda. Now, to put infrastructure in place that requires you to deliver this often is going to require high cost. We've just looked at a digital platform that comes at a high cost. So the first thing is the cost never goes down. And I've actually challenged people that, can we keep saying affordable and quality in the same line? But one of the issues I want to mention is that the vulnerable never ask for less quality. If you're elderly or sickly or, you know, the vulnerable in community, a refugee, would you rather have your maybe little mass excised without any anesthesia? You want it done properly. And so the vulnerable never ask for less. They want actually the same top quality that everyone else should get. The second challenge is the vulnerable is not a definite group. People walk into the hospital and think they can pay. And yes, but by the time we're through with investigations, you've done an MRI, you've done an endoscopy, we've done a few labs, we're in 4 million shillings, and now you need surgery, and the surgery is 5 million, and afterwards we might say chemo. You came in as someone who could afford, and all of a sudden at the end of your journey, you're becoming vulnerable. So the vulnerable, any of us actually seated here, as Director Clinical said, could become vulnerable. And this we see a lot. People will walk in with the mindset that they have the ability to pay. By the time they see the bills, some are like, you've got to be kidding me. When did we reach here? Giving treatment on the pocket. Know what we call the blanket sign. The blanket sign, for those who are not practicing medicine, is we look at the quality of your blanket and determine how much you can afford. So I'll say, no, don't do a CT scan, treat clinically, because this blanket is 20K, a 20K blanket. So we use the blanket to determine how much you can afford, and therefore we give the health care based on what you can afford. And that puts us downstream in a lot of problems, because then the health care is not evidence-based. You wanted me to deliver evidence-based care, but I had to deliver what is within my means. I'll ask my colleague to take on from here, Dr. Patrick.
Yeah, I think the question was about the provision of affordable healthcare, not so? Now, of course, our topic was mainly to do with universal health coverage. And I think as we discuss this, we need to know the major components of universal health coverage. So there is an area to do with access. There is an area to do with quality, and then there is an area to do with equity. Actually, as this was being designed under the SDG, Sustainable Development Goals, we want to see a situation whereby no one is left behind by 2030. So with that perspective, the issue is, how do we ensure that the lowest of persons can actually access health care, which is accessible and of good quality? Now, all these rotate about health financing. And it's important as hospital managers for us to get that perspective. So, for me, I'll base from the experiences I had when I was managing a hospital back then, up country in Arua, 200 beds, of course with a low income capacity. Now the way we went about that was to introduce fees that were definitive in certain areas. I know some of these may not work in the current situation, but the way it can be practical is through a national health system. So even the community health system. Because if those are working well, the payments are definitive and as such are paid by persons and then they can access health care. One of the things that we tried to do as UPMB was to introduce community health insurance. And slowly, we have been trying to push for the national health insurance as well. So it's not until when we make those definitive payments that are affordable to the lower community, it will then increase on the available funds, what I would call alternative financing options. Of course, we are also struggling with the government to see that they increase the primary health care allocation. At the end of the day, I think if we don't address the financing options, then we shall remain in a very difficult situation. Thank you.
Thank you, our panelists. My summary here is that the cost of delivering the services in health units or hospitals is high. But also the changing environment, including technology and people's expectations. And that national health insurance should be the answer to address issues of access, issues of not leaving others behind. The audience will be keeping some questions. You will be given a chance to ask your questions, you write them down, and then I will ask other panelists to respond to another question. The second question is looking at opportunities. What opportunities do you envision that government, hospitals, and partners can leverage on to provide health care to the vulnerable, the most vulnerable? Gerard and Johnson, you can share this question. Thank you.
Okay, thank you, Moses. So I think I'll go first. And before I start, maybe I'll give a very, very brief introduction of what our project does and how we come here, or why I come here to participate in this discussion. So I mentioned that I come from UHSS. So you got UHSS, as you can hear, health system strengthening. We look at, we are funded by USAID, and we have 3 key result areas. The first one is governance and leadership. So some of my team members go around in regional referral hospitals, setting up boards, management boards, and all that work, supervision. The second one is improving mobilization and use of health resources. And we are talking about finances and human resources. The third one is community health systems, supporting community health systems. But the area I lead is about health financing. So the goal we try, when we support the health system, we are trying to, one, look at how can the health system raise more resources to fund health care. 2, even the resources that are raised, how can we utilize them more efficiently so that you buy more care from the resources that you have. Of course, that comes also with deciding what to purchase and not purchase what the people in that area call strategic purchasing. Now, very related to the discussion today, as UHSS, we've been trying to see how can we support community-based insurance schemes. So in sometime last year, I think in August or September, we commissioned a study, what we call the landscape assessment of community health insurance schemes. So some of our teams may have come to your schemes to find out about what we have. So and the goal is to see what's there, what are the challenges, and if we are to come in and support, what can we support? What interventions can we put in place? So that's why it's an area that is of interest to us, and we are happy to participate in this discussion because it will inform some of the strategies or activities that we may put in place. So now coming to the opportunities that exist. So from the assessment we made, of course, we found that a lot of the schemes collapsed, but also a good number have survived for many years, 5, 10, we've heard about CZ, more than 20. So there is already examples of schemes that have been resilient, that we can pick lessons from and spread them or use them as we encourage other communities to set up such schemes. We could borrow lessons from the ones that have been able to survive and successful. And for the ones that have been around, and for all the time we have had these schemes around, they've put together structures. They've picked lessons. They've documented them. So we are not starting from scratch. We discover there is a lot of knowledge out there. There may be a few issues here and there. There may be a few challenges, but there are also a lot of platforms that we can build on. And I think actually Streamline comes into that picture, comes into one of those platforms that we can build along and help support, increase the coverage and also have more schemes set up. Also, I think someone has already mentioned in the earlier discussion that Ugandans rally around a lot of initiatives. So we are talking about SACCOs, we are talking about all these groups that communities get engaged in. So there is already a spirit to come together. It's all about what may be needed now is to bring people around the health cause. So that, I think, is an opportunity that we can build on. Maybe the last point I can make is what has also been mentioned, but emphasize that the NHIS, National Health Insurance Scheme, is coming. But the opportunity is that we are now in the formative stages. It's not like the scheme is there and you're trying to bring these community schemes into it. We have an opportunity to make them an integral part of the NHIS as it's being built. So we could seize on that and make sure we build synergies around the national scheme, but also around these community schemes. So I think I will mention only those few and pass on the mic to my colleague. Thank you.
Thank you, Moderator Moses, and my fellow panelists. I'm Johnson and Inda. I work with Health Partners Uganda as a program manager. I'm responsible mainly for making sure that health cooperatives can be established between communities and health facilities so that people can be able to access the care they need when they need it. And as health partners, we've been doing this work for the last 20 or so years. and there are about 15 health cooperatives registered, basically for delivering community health insurance, but on a cooperative model. And we are currently supporting 8 out of the 15. And I can say they are also trying to see that they can better their work so that the community people they serve can benefit from low-cost care. But coming back to the question about opportunities, one, I want to first say that the opportunity that is there is people. People are there in the community. They already come to our facilities. But they don't pay when we treat them. And we also encourage treating them on credit or confiscating their property if the worst goes to the worst. And these people are an opportunity, are a resource, because as we heard, they are already in groupings. And these groupings mean power. We have so many sayings around coming together meaning strength, working together meaning strength. And so when we really look at the power that is in these groupings, then we would know that it is an opportunity that we have not tapped. And so health cooperatives get registered when existing groups come together and say we want to overcome the challenge of catastrophic care. And they register a health cooperative. You need only 30 people to register a health cooperative with the Ministry of Trade, Industry, and Cooperatives. And then that cooperative will attract other people with their dependents and families. And these people make a big force that will actually come up to pay up their premiums up front to the facility, and then the facility is the one that will give them care without a third-party manager. It is so amazing how hospitals sit back, private insurers come and make money from them. It is very, very amazing. And at the end of the day, the private insurer pays you when they feel they should. Some of you are struggling with them. You treat people, to pay you becomes a problem. Start saying, how could you give this? There are business people like me who didn't study medicine, but they are tossing you around to give you money which you worked for. So for me, people are the first opportunity, and we have to get out of the labs, maybe out of the clinics, and find some extra way how we can reach out to these people. And the other opportunity that is there are existing cooperatives. For us, we are helping to plant and nurture health cooperatives, but we have so many other cooperatives that are already there. They are in the environment, like the minister said, housing, transport, then finances, the circles. That is a big resource. They are already structured. They have leadership. All they need is to add health as another component within their products. And once they do that, all we work out with you is to work out the modalities. What kind of MOU are you going to give them? What benefits package are you going to put there for them? What premiums matches that benefits package? But the problem that I see is that we seem to be in a rush. We don't have time to sit down and design strategies to reach out to these people, talk to them. We have schools around our facilities. They are big resources, they are people. For example, if a school has 2,000 children, only those can be enough to run a facility, and it really gets that prepayment and boosts their income. Otherwise, for me, I say the biggest opportunity are people around us, and those people have to be taught. So in a cooperative, we work based on 7 cooperative principles. These are international. One of them, which is number 5, is education, information, and training. If we are not ready to train, to educate, to give information, there's no way how people are going to know these things exist. So I've seen people have been given motorcycles. That's good. They are going to be given iPads. All that is good. But if you sit with them, nothing will happen. When I used to work as a coordinator for one health cooperative, I moved when I checked the odometer of the motorcycle. I checked, I had clocked like 10,000 kilometers, which I had moved trying to talk to people. So for me, the biggest resource or opportunity remains people, but how do we bring them on board? So bringing on board these people so that they can learn, they can appreciate is something that will not take 1 day, 2 months, 3 months. It will take quite some time. So the grant from your funders of 2 years, maybe you will use that time to only do this launch and also talk to some groups. But otherwise, this is a mindset change project that needs people to learn. CIS has taken over 25 years, and so we need more time. Lastly, on opportunities, women should be included in leadership. Again, this is about people. They are the ones who take care of the health needs of all families. Even some of the doctors, you find the wives are urging them to go and do some checks. So, because of that, in the model that we promote as health partners, we encourage that at least 2/3 of the leadership should be women. Why? Because they are the ones who face most of these challenges, and if they are not, then we will have people in leadership that are not motivated, that do not know the actual challenge on ground. Lastly, because of time I would have gone on, you need a lot of local partnerships as an opportunity, because these partnerships help to penetrate where the users of the services are. And once these are penetrated, then schemes like health cooperatives, community health insurances, Streamline Health, Ubuntu, all those will penetrate people and people will know what you have. We cannot come to your farm to buy your supplies if we don't know how it tastes, how good it is, how it has been talked about. So I think for me, the biggest opportunity is people, and we are over 40 million people, so we could change if we really invested a lot in people. Thank you very much. I'm sorry, I've taken a little bit of time, but it was necessary. Thank you.
Thank you so much. We've been reminded that we have opportunities and that we need to document. People being one of our big resources. People are there. And importantly, Ministry of Trade will help the legal framework. I think some of us have been operating not knowing our legal status. But also, you are talking of women leadership. When you look at our communities, women are very active, and that's such an important point that you raise. Documentation is important. What we are doing, like in XIS, are we documenting this? And Streamline should actually be part of that. Taking advantage of technology, Streamline is here, and taking advantage of funding like this one. We need to raise more resources. I'm glad Gerard is around. He will give you support in research. Gerard also talked about efficiency. Those are some of the key points that are raised, and therefore we need to keep note of that. The other last question, in the interest of time, Patrick, I'll ask you to be the one to begin, but any one of you can share. It's a general question. It's what needs to be available, so we need enablers. That's to ensure every single person has access to a full range of quality health services that they need, when and where they need them, without financial hardships. Because we notice that our people are not protected in terms of spending when they are sick, when the bills are big. So you can take us through the enablers, and I'm sure Gerard and Johnson also add on that. Thank you.
Yeah, thank you. Now, in terms of enablers, I think in our network, now I think since people are talking about their places, let me also talk about ours. In that we have a wide range of health facilities that are located, 80% are located in rural communities. Now, What we want is to make sure that they move away from a situation of dependence. Because as you are all aware, much of our work has been either supported externally. So our dream is to bring about sustainability of services. So that's what we are really aiming at doing by making sure that they have proper systems installed and are working properly. So sometimes we are failing because where we have seen good managers, we find that a facility is actually growing. In terms of the way it's managing its resources, their efficiencies going on, and as such, they are able to reach out to many more people. But where we are having situations of poor management, then the reverse happens. So we are actually urging that the issue of governance and leadership has to be improved upon. Now, in terms of enablers, an online system is something which we are also supporting directly. For some facilities, we are providing the software, we are paying for it, and also providing hardware in terms of computers and networking. Now, the other challenge we are facing is how it can be used. For some, we have procured the equipment, but then they have failed to take it on. So we need to find ways of ensuring that these systems that we are trying to put in place, people actually take them on, and that way we shall have efficiencies that will reduce on our operations and subsequently have cheaper cost of delivering services. So the other opportunities which I'm thinking of, lately we have an arrangement with the church called CHIDO. It's the Kingdom Investment Development Organization. And in this, we want the facilities or the church leaders through the church structures to promote community health insurance, and we have actually set up those systems, and we've been able to deliver services to the clergy. So those are some of the ways we've tried to reach out through those other mechanisms. Yeah, thank you.
Yeah, thank you, Patrick and Moses. So what I can add is, to me, I think if you are going to get more people covered, more services paid for, insurance is about numbers. The more numbers we have that are on insurance, any form of insurance, private, community-based, micro, whatever, then the more chances you have to have cross-subsidization, the healthy subsidizing the sick, the old, the poor, the young subsidizing the old, and so that you have, and then also the bigger the pool you have of resources that is capable of taking care of all the costs that come along. So what we need to do is find a way of getting more people onto health insurance. This can be through having appropriate premiums that can be that are affordable to everyone or to majority, that can get people attracted onto insurance. It can be about quality of care, so that when someone comes and they are treated, insurance pays, this person doesn't come back tomorrow for the same care just because the quality wasn't good and they didn't get the outcome they expected. So that way you get to make those savings and reinvest them and get more people covered. We can also, the other enabler could be about prevention and more prevention and more prevention. stop these people from coming to hospitals and health facilities for services that are going to cost the system. I am glad Streamline has that component, but keep them out of hospital by keeping them healthy in their homes so that that cost is avoided. So I think those are some of the areas that we need to look at as we push for that. Thank you.
Thank you so much. Colleagues, I want to say a huge thank you to the organizers. They did find very able people to discuss these points. So thank you so much. Now, I will talk of the numbers in insurance. That's very important, Gerard. But also issues of management, like the example of Kisizi, administration costs must be low. Benchmarking is very important. I remember Kisizi, we went to Goria in Kenya, and we borrowed some of the skills and things we learned for Kisizi. But also a stakeholder analysis kind of thing. Identify people you can partner and work with. Because when we worked with microcare, we thought it was a good thing, but we didn't do a proper due diligence. So be aware you can partner with some liabilities. We are time barred. I'm going to allow the audience to ask questions, and then we bring this one to a close. Thank you. Can we move the microphone around?
Thank you, gentlemen. I just wanted to know, like for starters, the optimum number of clients and probably the comfortable amount that premium that they should pay each. Thank you.
Thank you, moderator. I am Dr. Bexon from Ruhara Mission Hospital. I'm directing my question to the health partners. What has been the experience of health partners in supporting the health facilities to better their health insurance schemes and cooperatives in terms of sustainability and of course going forward into the future, their experience on ground? Why I'm asking is I seem to see some bit of maybe duplication of duties, because I think Streamline is coming in to support or to further the efforts that health partners had been doing before, partly, maybe not fully. So I needed to know the experience of health partners in supporting the health facilities in that accord. Thank you.
Thank you. Thank you very much. I'm Dr. Mumbere from Thank you. Yeah, I happen to come from a rural community indeed, and we have issues.
I let me ask my panelists to respond to the questions raised. Thank you.
Okay, I'll take the question on what numbers and what premium. I'm not the most qualified to answer that, but our understanding is the more the merrier, you know. The more numbers, the less the premium goes. It's a calculation. If you heard one of the speakers saying in Uganda, we have few actuarial scientists. There's a calculation we can make that you want, you bring in more numbers, and so if you're 10, your premium may go, sorry. All right. All right. So I was saying that okay, so I was saying, if we are 10 and the amount of money we need to raise requires us to pay 10,000, if we become 100, we can pay 1,000. So our premium improves. But there's something more about numbers. And Moses in his speech mentioned it. He said something called adverse selection. What people tend to do in families is that they choose this. I have, you know, my wife has an insurance that gives her 2 people. And so we selected in the family who should go onto the insurance. Who do you think goes onto that insurance? It's the most sick one. And that's what we don't choose. So those are not the numbers we're looking for. What actually? Numbers that are unfiltered, so that we hope that the numbers we select have some people that will need health care and those that most likely might not, because this premium will cover for the others, so that this does not adversely affect the others. So quality numbers, and the quality numbers then bring us better premium. So that's how we can say there's the more, the better. And so I know a scheme, I think it's Sepwell, that taught me that they don't take you as an individual, you must come as a family, so that everybody, the risk is spread, rather than when we decide to take numbers that are. Thank you.
Thank you.
Okay, thank you very much. There is a question from Ruharo about the experience in supporting health cooperatives and towards sustainability. And he's wondering whether there is a duplication between what we've done and what Streamline is going to add on. I should say that Health Partners is funded by USAID to support local-led initiatives. And these local-led initiatives should eventually be owned. They can't keep depending on the donor. And so when we are doing the work that we do, we give people knowledge to catch the fish. We don't give the fish. And we do this through letting people know that we cannot pay for premiums, for example. We cannot pay for their membership fees, annual subscription. We cannot pay for copay. Everything is on them. And even the facilities and the cooperatives, when we are working with them, we give them seed investments. We give them, we support trainings, we support meetings, but we cannot put money into treatment, into other things that they need to use on treatment. And so we look at building the capacity of stakeholders like cooperatives so that they manage insurance mechanisms. How do we do this? The board of directors who are elected are the ones that are supposed to go and see what the care provider is doing, not Health Partners. And that is one way of empowering them, of creating sustainability. The board of directors and the group leaders are the ones to go back to the community and teach them, not Health Partners. Because if Health Partners goes there, they think the schemes belong to us. So we want people to see that actually they are the owners, they are the users, and they are the beneficiaries. And that way, they will have to learn how to manage it. For example, if we have a church in our community, we are the ones who manage the funds of that church and everything, if we want to put up a new structure and all that. So even an insurance scheme that is community-owned and managed should be looked at in the same way, that it is ours. Then the other thing that we have seen is that facilities tend to think that once you introduce a scheme to them, Streamline, then it is yours. No, you have to go with the upfront message of showing them that actually this is their scheme. You're just partnering to set it up. But when it comes to sustaining it, it is their primary duty, not the duty of the donor or UPMB or UCMB, whom they have come through to have the initiative established. So we have sustainability at the back of our mind, and to that end, we look at ourselves as a capacity building organization, and the rest of the work is dropped back to the community to manage. I think that's what I had to respond to.
Okay, so I think I'll take very quickly answer the question about taking advantage of government programs. So government programs like for the elderly. So to answer Juliet's question from SHU, the quick answer is yes, that's an opportunity. But in reality, I think it's more complicated than that. Because how much are the elderly getting from these programs? I think last time I checked, it was 25,000. Maybe now it has increased, but 25,000 for a month. So if that is supposed to take care of this elderly person's needs, assuming they have no other sources of income, how much can you get out of that as a premium? So yes, it presents an opportunity, but again, maybe it would be easier if the numbers were bigger and the premiums were so low that if someone commits in maybe 5,000 or 10,000, it can cover their premium requirements. So yes, but we need to think about it a little more. That's my quick answer. Maybe I'll leave the rest of the questions to my colleague, Dr. Patrick. Thank you.
Yeah, thank you for that input. I think it has been very well covered. Now, there is the issue of forming partnerships, which is very critical. For most of these insurance schemes, there has to be a startup mechanism. We have seen, I think the example I can give is Bwindi Hospital, where they have formed a network in their community, very, very wide network, where they provide health in an insurance mechanism to the extent that they even know the homes of these persons. They have pin drops where these people stay. So they have established that kind of network, but it was supported externally. So that then people get used to it, and then subsequently they take it on as a mechanism. Because as they report for health care, I think then maybe the situation has changed, but when it came to the actual seeking of services, they were only paying 1,000 shillings on top of the premium. So partnerships are very, very important. So we need to look out for funding partners. Then about trust. Indeed, what is failing most of our institutions is the way they are structured and with the lack of systems. And indeed, once we have good systems, then it should work out. One of the proposals that have come to us is to establish an e-wallet system specifically meant for health care, such that this money, really, it is your money. You identified with your SIM card, but you can't withdraw it for other use, except when you are going to seek health care. So we are in the proposal writing mechanism, such that however little you have, you know, people sometimes earn 1,000 shillings, 2,000. You can actually upload it and you contribute towards your health. Even if you do it on a daily, or 500 or 1,000, within 365 days, you should have covered the what? The available premium. So those are some of the mechanisms that we are looking at, especially when it comes to collection of funds. It's really an idea that we're trying to look to. Okay, thank you.
Thank you, Patrick and team. I had hoped they would have closing remarks, but we don't have time. But let me make this point that emerging of non-communicable diseases, the incidence and prevalence is a threat to some of our work. We need to be aware of that. But also, too, issues of sustainability are a huge challenge. Should we be thinking of reinsurance? But the kind of premiums they ask these big companies is huge. 3, the Axis experience to try and avoid adverse selection. When you are recruiting groups, there is a number, a magic number that has worked for us. 60% of the members must join if you target a group. I don't know the science, but it has worked for us. Talking of coverage for 6 weeks or 4 months or a year, what has worked for us is a year. It's like a mother when she's expecting a baby. I prepare for 9 months, I keep saving. So if it's a year, it's easier for you to plan and save for 12 months and get the premiums. But some of the groups are so advanced that they have the money up front, so you pay back. It's like you are borrowing from the fund of the Ngos group. A huge thank you to the team. Please make sure you share your questions. It's been a joy and privilege to moderate this session with capable, able people. How I wish you had more time. Thank you.
A much bigger hand clap, ladies and gentlemen. Thank you so much, Mr. Mugume. A session well moderated. Thank you, panelists. You really responded very well to these questions, and you were also very articulate in pointing out some of the issues to do with health financing. Such a broad subject we cannot exhaust in a short period of time, but you gave it your best. Thank you so much. Another hand clap for the panel. Ladies and gentlemen, I know that we are running out of time, but we are on schedule. So we are going to have one last panel that will run from 4 to 5 p.m. and then we shall close the session. We have a guest who is going to close this launch. We will be introducing him as he arrives. But ladies and gentlemen, let me introduce the second panel in the interest of time. The panel will discuss the topic that says the role of technology in improving access to affordable health care. And it's going to be led by Mr. Moses Waweru, the Senior Program Manager at Vilgro Africa. Please let's welcome him. Mr. Waweru, you're welcome to modulate this session. And he's going to be working with a team of panelists that I'm going to read. They'll come forward. I'll be very brief because I don't have the detailed bios, but they'll be able to introduce themselves. Mr. Mbaka Paul, please come forward and join the panel on these seats. Mr. Mbaka Paul, Commissioner, Division of Health Information, Ministry of Health. Is he here with us? Dr. Solomon Kamurari, Program Manager, Uganda, UK Alliance. Is he here with us? Yes, please welcome him with a hand clap. Happy to have you as part of our panel today. Mr. Wens Bender, ITUSD, USAID, UHSS. Please welcome him. Please. Happy to have you on this panel this afternoon. Mr. Patrick Joram Mugisha, Managing Partner, is it Innovate Labs Africa? Innovent. It was actually written right. I modified it. I apologize. Innovent Labs Africa. Please, let's welcome Patrick Joram Mugisha. And finally, Mr. Faisal Lubega, the CTO of Streamline Health. Please, let's welcome him. So we are going to listen to them take us through the role of technology in improving access to affordable health care. Sorry? Okay, yes, I will. Yes, so I'm handing this over to you, Mr. Waweru.
Thank you very much, Lydia. And first of all, thank you to... Can you hear me now? Great. Thank you very much to Streamline under the leadership of Samuel and Dr. Ian for inviting us for this event. And also thank you to Dr. Mugume for bringing us back to schedule. We were running late, but we are currently on time. So I will move over there and get us started with the panel. So can you hear me? Before I get started with the panel, I want to just take a few minutes to speak about my organization, Vilgro Africa. So Vilgro Africa is an impact investor and business incubator focusing on the health sector. What we do is we provide funding and technical assistance to early stage companies in this sector to bring to market and scale innovations that are targeted at improving access to health services and health products. And we work across Africa. Since we began in about 2015, we've deployed about $2.6 million. And one thing that's very interesting is that about 50% of our portfolio is in Uganda. So maybe a big round of applause for yourselves as Ugandans, because what this means is that we get about 600 applications every year for incubation and investment. And out of those, over the last 7 years of operation, we've seen a very high quality of innovations coming out of Uganda. And because we have a focus on hardware, we have seen Uganda producing very high quality hardware and service or software or business model innovations, as we call them sometimes, which are innovations that are working towards improving processes. So with that brief introduction, I'd like us to now move to the panel. So this panel is looking at the role of technology in improving access to affordable healthcare. And in this particular case, we are talking about electronic medical records. And so I'd like to start us off with the first question, which is around the challenges in the health system and at facility level that electronic medical records are able to solve. So I'd like to throw that question to my first panelist. So what kind of challenges are there in the health sector that electronic medical records for every patient can solve? Thank you.
Thank you very much, the chair of the panel, Moses, our dear participants, and then of course the team from Streamline for organizing this very important event. Like I was introduced earlier, my name is Solomon Kamradi. I'm a medical doctor by background, but I work with an organization called the Uganda UK Health Alliance, which is a partnership between the National Health Service for the UK and the Ministry of Health. Our goal is to see how we bring learning from the NHS into our health system here. And that's where we have a footprint in Streamline by having Dr. Ian Spillman as one of the co-founders and having worked for a long time in the NHS. So with that being said, just to pay attention to the question at hand about the role of electronic medical records for every patient and at the point of care. First of all, with learning from the NHS, for instance, electronic medical records have not been an easy thing to bring into the point of service. Even for a system like the NHS, which has an annual budget of around 190 billion pounds, it's only until around 2018 that maybe 60 to 80% of the facilities were able to bring electronic medical records fully on board. But still you have the service providers having about 21 systems across serving patients where you have challenges with interoperability. Now, coming to the setting of Uganda, first of all, the systems have not been easy to come by. Implementing at the facility itself has been a challenge in terms of resources, in terms of the human resource, and also usability. But nonetheless, there are success stories, there are silver linings. STREAMLINE is one of them, where patients are able to benefit, and a number of other systems that have been deployed across the country. I'll give an example to bring out the benefit for the patient, especially for remote patients. We had systems that were supported to be implemented in Bududa, which is very disaster prone. And this is a system that was established in a place where they never had a single computer. So, but within 1 month, the district health office was able to capture good statistics. So that shows you that even for the public health service, they're able to monitor the patterns of disease, plan better. At the health facility level, there was a lot of efficiency in terms of managing the pharmacy, managing the flow of the patients, patient care, patient follow-up. And to the patient themselves, just the facilities that had deployed these kind of systems, they registered an increase in number of patients, which showed that patients are also interested in quality improvement. It's not that they should always use the books that they can dispose, that they cannot come with at the next visit. So patients were able to appreciate the quality improvement that comes with the use of an electronic medical record system, being able to come to the facility and your data can be captured and retrieved. And then, of course, the things that come with patient follow-up. For example, in this kind of context, you have a lot of patients who are on chronic treatment that requires a lot of reminders for adherence to treatment. An example of patients who are taking antiretroviral therapy, patients who are on other chronic medication. So having a linkage to the system and linking it to simple reminders like SSD is a big winner for the patients who are underserved in the populations. Coming back to another group of patients who are able to access technology. For example, in our context, I will give another example in the context of Vilgro, where telemedicine now is penetrating in urban centers. You find that, for example, during the COVID-19 pandemic, many patients were hooked on a number of systems. An example of those that many of us in the room might know is Rocket Health, for instance. Even accessibility to healthcare for oftentimes the neglected populations, the urban population, is made easier, and the health-seeking behavior improves because patients are able to get linked to an electronic medical record system to a service provider, and then there is a way for follow-up and linkage. In the interest of time, I wanted to compare those two specific populations, the underserved populations and those that have access to health care, but it has not been made easy for them to access it. That is to paint a picture about how electronic medical records, when linked to follow-up, when linked to patient-centered, can improve care, can improve access, and can improve usability. Over to you, Chair.
Thank you very much, Dr. Solomon. Now, Mr. Wentz, I would like to pose a different question to you, but which is related. And that is, from where you sit at the UHSS program, what do you see as the opportunities that EMR can create in the health system context? Thank you.
Thank you so much. Wens Bender Twesja my names, and I work with UHSS, which is a USAID activity. I'm glad that my colleague has already introduced UHSS, so I will not have to go into that. But what UHSS does in terms of health information, we work with the Ministry of Health and partners to ensure that the systems in the health are strengthened. Now, you ask me of the opportunities. Now, you very well know that the underlying factor to having EMRs is only one. Because what is happening, we are looking for data. If it wasn't for data, we wouldn't be talking about EMRs, we wouldn't be talking about any system in the health sector. Now, you very well know that the government has made strategic initiatives. You notice that to date, most facilities report through DHIS2, but there is a big challenge of data quality. As you know, the way data is captured, like we were told, it's not in real time. So if you analyze the quality of data in DHIS2, it's quite alarming. And also you know that the timely acquisition of this data, because imagine you have to wait at the end of the month, at the end of the week, for the records to come through DHIS2. And when it comes to decision making, the report needed today, if it comes after 5 days, if it was predicting an outbreak, you know what that means. So by the fact that we need high quality data, there is a strong need for EMRs. And as we talk today, the good news, which is an opportunity, is that the ministry is spearheading a digitization agenda of health facilities, because they have seen they cannot continue with data clerks entering records in the system at the end of the week, at the end of the month. So there is a very huge program to digitize the whole patient workflow. You know that the sector is full of many systems. So you find one system is doing pharmacy, it brings this IP, one does ART services, another one does maybe for family planning, this one is for malaria. So there are many systems out there. And remember, we're talking of minimal workforce on the ground. So it's a very big challenge. The ministry wants to have an integrated system. So currently there are a few systems that the ministry is rolling out in the public facilities. And for Streamline now, this is a huge opportunity to create an impact in the private sector. And the way I see you are stationed, having one system that does all is going to actually be a good landing stage. So there is a huge opportunity that the ministry is running a program, and that creates a very good learning stage. Now, I'd like to talk about, you see, when you have these EMRs and you're getting data and is of quality and on a timely manner, I want to give you a short story in the interest of time. A couple of years back when I worked at UBUNTU Community Hospital, I think the doctors know the inequality, the issue of inequality. You know, when you sit at a hospital and analyze the data you get at the hospital, and you say we have malaria cases are rising and rising and rising, and you say there is a huge burden of malaria just because of people coming to the hospital, sometimes when you go to the community, it's not true. When we compare the data for the people in the homes who do not come to the facilities versus the ones at the facility, the findings were quite alarming. People in the communities cannot even afford the radio when you put an advert that comes for immunization. They cannot afford batteries. Their mode of communication, number one, is word of mouth. And you've seen the topography. They cannot afford transport. So for them, coming to the hospital is a luxury. when they can consult herbs, their witch doctors, and so on. So when Bindi Committee, what it did is that let us go to the communities in our system which we have in the hospital. Let us go to the communities which have shown to not have a certain disease burden, and let's do a screening for it. So you pick, you say malaria, in this village, it has the lowest rates. You go and say free screening. And the results were alarming. So sometimes the communities we think do not have malaria because of the data that has come in the hospital is different, because the people who need this health care cannot even afford to come, cannot even afford a mechanism of listening to the initiative. So having a system like Streamline that touches community level is a very big opportunity. Thank you.
Thank you very much, Mr. Wentz. And I like that issue that you raised of that disparity between what's happening at the community level and the data that hospitals are picking, and the opportunity therefore for Streamline to cover that gap. Now over to you, Mugi. Now you talked of having transitioned from the public to the private sector, and I would like you to take that same question that Wentz answered, but now speak to the private sector perspective. And the question really was what opportunities you see EMR creating in the health sector, but now from a private sector perspective.
Okay. Thank you very much. Hope I'm audible enough. Yeah, so maybe just allow me to respond to that by giving just a 1 minute story about myself. Right now, to be alive, it's by the grace of God. I'm a COVID survivor. And having gone through that bit of 2 weeks in ICU on oxygen, and then after that developing blood clots in the lungs, so I had to be on blood thinners for 6 to 7 months. So, but it happens that, well, again, I thank God for this, because I was born in a family where both parents are medics. But during the COVID time, my father was in Norway, my mother was in Kenya. So definitely there was no way they were going to move and come and be part of my support. But what I did was, I had a good doctor, and I thank God for him. He's called Dr. Kalika. And so every time he prescribed something, yes, I trusted what he was offering, but because I knew I had a strong background coming from the medical perspective, my parents, I had to share with them what the doctor has prescribed, and then I get their kind of like their opinion on that. When I had to go for a scan for my chest, looking at how badly it was, I had to send them the pics for them to tell me, so, guide, this guy said we do this, is it appropriate? So, in that space, that was just an example of again, how an EMR could potentially be quite helpful in this case, and going beyond the dimensions of these manual complexities. So that means transboundary nature of the technology just enabled this to be a possibility. So coming to the private sector, the whole point is there's an opportunity. There is an opportunity in this space as far as EMR records the benefits they bring the healthcare space. One, if as a practitioner you're actually utilizing some of these solutions, one, the efficiency that they actually present to your potential beneficiaries is quite enormous. So the sluggish space that or kind of like challenges that are always experienced in the public space, you realize the private sector, the guys want to run, but the public sector you want to walk. So the whole point is that technology gives you that added advantage. And so I think in the private sector, coming from the place where we really support these innovation support to these practitioners in the health space, then I think this is an opportunity for them because one, you're going to move faster, and again, if you're not kind of like trying to be caught up in the slow approach of the public space, then I think you've got a chance to make an extra income. And bottom line, again, maybe where we are likely to be caught up will be the point of policy alignment, because private sector, we don't make policy. It's the public sector that actually defines the policy landscape. Though we are consulted to make an input, but bottom line, the dynamics, and I'm happy Honorable is here, so these are things that are definitely always kind of like push us back as a private sector player. Thank you.
Thank you, Mugi. I really like what you said, that EMRs present an opportunity to provide patients with a level of agency in the process of their treatment. And going to Faisal, now the question for you is, from your experience at STREAMLINE, how do you see the data that you're able to collect translating to the actual saving of lives?
Thank you so much. Once again, my name is Faisal Vega, and I'm the CTO at STREAMLINE Health. Our CEO, Samuel, and the team have introduced STREAMLINE here. Basically, the collection of good data can actually transform or translate into saving lives in a number of ways. For example, if you're using an EMR like STREAMLINE and you embed world-known research, like Dr. Ian mentioned, for example, embedding ETAT to make sure that all the children coming through at triage are screened, not basing on the nurse's intuition, but basing on scientific research. So this means that now you can identify the at-risk babies, but you are using the EMR, you're using the data, you're embedding the research, the evidence-based research into the system. And this means that now the pediatrician is going to get a chance to see at most risk babies earlier. And this is how now you're helping the doctor to save lives. But it's based on the data you're getting from the system, which somehow probably the triad nurse may have ignored. That is one of the direct examples on how using a good EMR designed and developed based on evidence-based research can really help in saving lives. You may not see it directly, but actually it happens. Also, how, for example, we have the medical superintendents, they are here, the hospital managers are right here, but the hospitals where they're working, they don't close. So right now, they are working. So if they go back tomorrow, next week, they would like to know what transpired during the time when they are attending the STREAMLINE UBUNTU workshop. Probably they have clinic officers and the junior doctors running the clinics at this moment. So how does a senior doctor, like say Dr. Peter, would translate his experience to a junior doctor, to a clinical officer, if he cannot be able to quickly know what transpired during his absence, because he cannot reach to every patient to extend his specialty. Therefore, if you have good data and using a good EMR, then you should be able to see, for the last week I was away from my hospital, these are the number of patients that actually came through. But specifically, these were the red patients, which means that they needed urgent attention. So then you pick keen interest on how your junior doctors manage these cases. Sometimes you may find that the management was as proper as you expected. And then you can join to manage better, or you can train the junior doctors so that the next time you have such an occurrence happening, the management or the outcome are as accurate as the specialist would have handled if they were present. But you cannot have such benefits if for 150 patients seen today, you have them in files in a store, because you cannot go through all these files. So you create rooms for these mistakes to reoccur and keep coming up. Probably you can pick it up one day when you have lost a patient and you're having a discussion on what happened. But not always the patients may pass away, but outcomes may not be as expected. So really having good systems and good data can save lives in a number of dimensions. The other one can be is that as we see our patients throughout the month, throughout the year, we can now pick out trends of interest. What are our high peak months of the year, for example? And how should our restocking be? For example, if we have mothers delivering in a given month of the year, and we are quite sure about that, then with the limited resources we have, we can really spend where we have knowledge about. Do we need to stock blood so that if mothers are bleeding, we are ready? Do we need to stock a given type of medicine because it's going to be a peak of this time? You cannot do all that unless you have enough data and good and accurate data. If you have the data and utilize it well, and you stock whatever you need to save these lives, then actually you're using data to save lives. So the examples can be many, but really the benefits we get from good data really can be very, very, very helpful. But it's not only just data, because we can collect data on paper, and at the end of the month you tell your record assistants how many patients have we seen, how many passed away, how many have this kind of problems. Even that one is data. It has to be accurate, it has to be real time, and it has to be verifiable. That is the kind of data that can save lives. Thank you.
Thank you very much, Faisal. I really particularly liked the point that you made about integration of evidence and practice, so that on the one hand, we're generating data and learnings from the data, and then on the other hand, we're able to bring it back into the system to improve practice and therefore quality. So thank you very much, guys. This is a very engaging discussion. I'm quite happy to be participating in it. Now, moving on to another question, which speaks to the actual process of data collection. Coming back to Daktari, what role do you see mobile phone penetration playing in the process of creating access to a full range of quality health services for every person when and where they need it, and without creating financial hardship? Basically, how mobile phone penetration is impacting progress towards UHC. Thank you.
Thank you, Moses. Really, I think mobile phone penetration is a game changer in universal health coverage. In the context that, you know, we are being guided that 90% of the investments in healthcare should be made at primary healthcare, where about 60 million lives will be saved just with those investments. Now, my colleague on the panel painted the picture of the patients in Chisizi, where he mentioned that even then when they used to pass out communications on radio and other forms of media, you could find that these underserved populations, they cannot even afford those channels to get that information. So that's how costly traditional health promotion has been, and oftentimes ineffective. And here you are in a country like Uganda, where I think our mobile phone penetration now stands at about over 60%. So that means that at least in a homestead, you have someone who has a mobile phone in whatever form you have it. So if you're able to harness that, your health promotion, if let's say a streamline is covering the whole district and they have homesteads registered, so you're able to know that if you pass out information when you've registered one of the owners of a mobile phone in a homestead, then this information is able to reach the homestead. So that shows to you how mobile phone penetration can be leveraged for health promotion, for instance. So that is around primary health care. Come to facility-based care, where you have the traditional form of, for example, patient follow-up has been, you're able to discharge a patient, give them the dates when they should return, communicate to them the information that they should ideally carry with them home, and then you second guess that they will be able to adhere to their medication. They will be able to know when the dates for return, and this typically will be giving this information to maybe a semi-literate patient who will not take 50% of the information. But with mobile phone penetration, we are seeing that a number of healthcare providers are able to leverage this information to improve patient follow-up, to improve adherence, and generally outcomes of care. I'll give an example of Heart Institute. Currently, I think the penetration of cardiology services in the country are quite centralized. So you find that the Heart Institute is oftentimes overwhelmed with numbers. And these patients come with all sorts of complaints, ranging from complications of heart disease, but also those that might need just basic triage. So what did Heart Institute do? They invented something called Save Life, where they're able to get their patients within their directorate, get their phone numbers, and the patients are able to send prompts before they even come to the facility to know, to send prompts in terms of how they feel, if they need any refills, if they need any guidance, and then this information is synthesized within the system of Heart Institute to be able to say, look, you can do this, this and this, you can go to the nearest health facility. And in that, this is using mobile phone penetration to reduce congestion at the facilities, to triage patients, and actually to also reach out to patients in time before they come with complications to the point of facility, and oftentimes when the services are highly congested. It is the same drive that is happening to the other specialized centers, be it Cancer Institute, to use mobile phone penetration to reach out to the underserved populations in time where they are. Instead of having a patient travel from Gulu to come to Heart Institute when they would have needed just an intervention at Lacho Hospital, you're able to save them all that amount of money. It comes back to sending them their diagnosis and at their point when they can receive it. So I think it is a real opportunity for Streamline in the areas that you serve to really leverage this kind of system, integrating it with mobile phone penetration to see how we can deliver interventions efficiently, effectively at primary health care level, and then also at facility-based care level to make sure that the patients actually receive this information without necessarily incurring costs that they would have otherwise incurred using the traditional methods of health promotion, access to care, etc. And then lastly, how we are integrating phone penetration into health service delivery. I will give an example of recently we had an Ebola outbreak, and how some of the patient movements were able to be tracked, and how some of the epicenters were able to be mapped out. We're able to use the community health workers who have mobile phones that have GPS technology linked to the epidemiology centers that had been deployed. And see that even beyond the patients themselves, the actual service providers, from community health workers to the facility health workers, there's a lot of benefit that comes in with just using a mobile phone. Beyond the health worker, for example, our health workers here, for you to have meaningful access in terms of universal health coverage, a woman who is pregnant, it's not just about them being able to access a health center. They should find a competent health worker. So there has been a penetration of clinical support tools for the health workers to be able to provide better care, which in turn benefits the patients. I think Streamline, I'm happy that in the system there are prompts for the health worker at the point of service delivery, to know that if they're able to, if they have a patient, they can use their mobile phone maybe to access ETAT, maybe to access the Uganda clinical guidelines to provide better patient care, which in turn benefits the patient and makes access to care more meaningful. So mobile penetration in a nutshell is increasing access to the patient themselves, improving effectiveness in terms of health promotion, looking at effectiveness in terms of healthcare delivery, and then lastly, what we are discussing before this panel, in terms of de-risking the markets. Oftentimes, these insurance companies want to know what numbers are accessible. It doesn't matter when you say that we have 45 million people, but how many are accessible? So the only mode of accessibility now is oftentimes through mobile phone coverage, because you know I'm able to access the following number of potential clients through mobile phone coverage, and that can be actually a leverage point for you to say this is the mobile phone penetration and this is the anticipated access to the population that I want to maybe target with my intervention, and that in a way helps the person who is investing like Vilgro to say, look, there is a semblance of penetration, there is a semblance of access to the market, which in a way, if I'm putting my money here, I know there is a level of de-risking because of this kind of penetration of technology and mobile phones as a proxy. So I want to keep it at that, and maybe the other panelists can leverage as well.
Thank you. Thank you very much for that very well-detailed answer. Over to you, Mr. Wentz. Same question, really around mobile phone penetration.
Thank you so much, and thank you to my colleague. I think he has demystified this question, and the rest of us will be giving add-on. When it comes to mobile phone, you know, it has changed this economy. If you look at how telephone companies have played their game with this gadget, it's an indicator that there is a lot the health sector can borrow a leaf from. Because who knew that to date, without signing any contract, you can borrow money from these telephone companies. They base on your transaction history, and they are able to do some prediction and assess your risk and give you money. And you've heard in the news how it's been a profitable venture. So if these private companies can be innovative to this extent, I believe even us in the health sector, we have a lot we can do in leveraging this device. This device, when it comes to financial access, it's an open secret, because I'm sure some of us have taken a loan while going to the hospital. So that's one way this gadget has helped. People are able to gain finances using this gadget, even if it is not through these telephone companies. But we have a lot of elderly people. Most of us take care of our elderly people in the villages, our grandparents, grandma, aunties, and their only lifesaver is the network. Any emergency they have, they give us a call, and we're able to help them, send them some money. So that communication is very, very key, because without communication, even when you have an emergency as a mother, how will you call someone to come and help you? Remember gone are the days when you would have to send a young kid at 3 a.m. to walk 3 kilometers at 3 a.m. in the night to call for the help that my mother, who is due for delivery, has a complication. To date, a phone call can be made, and that saves a lot. Also, not forgetting data collection. We can collect a lot of health-related information using the phone, basing on the alerts and the interactions we can have with the patients. We can collect a lot of information using this gadget, and we can also communicate a lot of public health-related data through these phones. So if we have, of course, there are also challenges in communities where even deciphering this information is a problem. We've seen cases where messages are sent to, say, the VHTs, and these VHTs, since they are across the homes, they go home to home explaining to them what the information is about. So we can use these systems to communicate to the patients. We can also provide a lot of public health related data to the patients. And lastly but not the least, when we talk about telemedicine, it's not only the teleconferencing where you have a big video gadget. Like my colleague has mentioned, he consulted his parents. Yes, he might have used WhatsApp or an email, but he could have still sent a text message, even if it's a basic phone, or they could have made a phone call. So telemedicine is very key. It is a new field that we are trying to embrace, especially in the developing world. And it can help you speak to a senior consultant that is in another continent or in another district, and you will get saved, because that expert knowledge, you may not be able to afford it being available in the community. So I think to us as Uganda, especially as Uganda, which is a very good case study of a developing country, leveraging the mobile device can do a lot of benefits to us, and we can actually benchmark on the telephone companies who have really leveraged this technology to make a lot of money, and from the very people we would like to serve. Thank you.
Thank you, Wens. So we'll shift gears a bit, but pick up on something that you said. You talked about the possibility of prediction. And this brings us to the subject of artificial intelligence. And I'd like to throw this question to you, Mugi. What role do you think AI will play in making healthcare affordable?
Thank you very much. Thank you very much, Mr. Moderator. And maybe just to clarify something small from what my brother Wensa said. He talked about telemedicine. And it's quite interesting that today whenever we talk of health interventions, we forget some bits of indigenous knowledge. I mean, as Africans, we've always leveraged on indigenous knowledge. And I'm Amchiga from Kanungu, and we did have and we still have guys we call traditional bone setters. A bone setter, you break your leg, limb, whatever, they will call the guy and the guy will tell you, you don't move, but at this time, I'll do something, you'll feel some pain, you'll be okay. That's telemedicine. Just that maybe this term just came the other day with ICT gurus, now the SAMs saying that let's call it telemedicine. That was telemedicine. So actually, honorable, in your committee, these are interventions that we need to integrate. We just make sure that we just sugarcoat them, but they work. They work. So, AI, artificial intelligence. Anytime we think of AI, it's a question of data. AI feeds on data. Garbage in, garbage out. You give it the right data, it will give you the right output. But again, I think what is making this a possibility is that, again, on one point is that we in the LMICs, low middle income countries, maybe for example, Uganda as a case in point, we have data, but it's not digitized. Too much data in the health space, but majority of it is not digitized. So it becomes very difficult for it to actually form a very good input into whatever we are trying to design around AI interventions. But with availability of data, if it is controlled, collected, and being able to be integrated, then solutions can actually be developed. And a case in point is what Streamline is doing. Let's not go far. In their platform, there's that final bit, which is the AI intervention, which brings that unique value proposition. So the whole point is, I mean, how would you tell me that today Streamline can give you, or maybe Kisizi Hospital, to pay, is it 20,000 per year? 20,000 per year? 24,000 per year? So Sam, if that's true, then to me I'm happy to be a marketeer. I'll get all these guys in the corporate world to sign on your platform. Maybe I'll just increase it to 50K. The rest is my markup. They will fill your platform. The thing is that, so it's an issue of data. It's affordable. You have made it affordable. And I think when you tell some of the, I don't know how you're going to negotiate with these big insurances, when you say for you can give a premium of 24,000 per year. I don't know how you're going to navigate around that because it's disruptive. So the cheapness that AI presents, Mr. Moderator, is that it can be disruptive. A case in point. Today you look at, there are so many wearables. I think in the room there could be colleagues here who are having wearables. It takes your smartwatches, all your essentials or vitals. It can actually tell them. You don't need to walk to any clinic. It can tell you, and it's actually accurate to some degree. It's affordable. You'll buy the watch once, you'll always get this information. So I think, Mr. Moore, let me stop at that point to allow maybe other discussants to come into play. Thank you.
Thank you. Thank you very much, Wens. Sorry, Mugi. Now over to Faisal, and just to answer the same question, you have been collecting a lot of data. What opportunities are you seeing in terms of AI as a means to solving existing challenges? And on top of that, alluding to something that Mugi talked about, are we collecting the right data? So are we setting ourselves up for success when it comes to application of AI?
Thank you so much. AI is the new era that is here today, and I think it is promising to change how we work, how we live, how we play, and also changing the healthcare space. Of course, we still have a journey to move, but I think it is really the new technology that is going to change how we work, especially how we see data at healthcare, in healthcare. Like at Streamline, yes, the hospitals can collect data, the EMRs can collect data, but if you're using a good system like Streamline and you collect good, accurate data, then AI is going to help you really move the hospital, the managers, from data to analysis. That's what has been there for years. We would get data, we would analyze it. But now we need to move from analysis to insights, and from insights to wisdom. And now that is going to give us the confidence to give the managers, the politicians, the confidence to lead with data. Otherwise, if you're not leading with data in today's century, you're moving in the dark. And some of the data we are collecting is helping us to know, for example, he has asked, how do you set a premium that low? The question would be, what is the basis on which you set your premium? Is it set on a basis of fearing to make a loss? Is it set on a basis because you want to make a profit? Is it set on a basis of affordability? If any of those is your line of setting the premium, do you have the data to inform you and be confident that at 24,000 shillings a year, I can provide acute care? And this is when AI comes in to really help us look through the data of the years, map out the trends, and then give us insights on what is, for example, the average cost of a patient in a given facility or in a given location. such that you can be confident that at this premium, my patients are unlikely to exceed this boundary, and you're setting that with confidence, and AI is very helpful in that. But also, you'll give people services, but again, it's not uncommon that you have fraud cases. Some people are going to try and misuse the services. And AI becomes very important in picking out those fraudulent cases so that we can be able to really be able to know that the hospitals are providing services to the right patients. And that's some of the areas where we're applying AI to make sure that we can help hospitals provide services to right patients. Give them insights and knowledge to be confident. Map out, if you're going to change premium the next year, you should be able to predict the trends in the next 2, 3, 4 years, and so that you're confident about your pricing. And AI is really very helpful in that. But away from that line a bit, also you can come to, for example, in giving care. AI is promising that, for example, diagnosis and surgeries can be a little bit cheaper, or the outcomes can be better. The surgeon should be able to stimulate a complex surgery from an AI model on a computer before he performs the actual surgery, and is likely to see the likely outcome based on the patient. And this is likely to improve the outcome of the main surgery, which was not there before. And if we can have such kind of technology, I think the level of outcome improves, but also the cost keeps reducing, because we don't need to have very high level specialists in every facility, because AI can help in to bridge the gap. Thank you.
Thank you very much, Mr. Faisal. So now to my last question, which I will direct at Solomon and Wentz. And this is a question on ethics and regulation. Now, the minute you begin to talk about data collection and collection of personal data and health data, you start to get into questions of ethics. So now my question is, what role are you both in your different organizations playing to address those concerns? And I'm not up to date with what the regulations here in Uganda are as far as data protection is concerned. Maybe as you answer this question, you can speak to that and also speak to the gaps that regulation should address. Now, one other thing that's important in this discussion is, earlier in our conversation, we were talking about how it's always best, and I think it was you, Mugi, who alluded to this, when innovation precedes regulation. So as you answer your question, put that at the back of your mind and please give us some perspectives. Thanks.
Thank you, Moses. I think that is a very interesting question. I'll speak through the process of data protection and ethical consideration that happens typically in Uganda. So for example, when you have an electronic medical record system or a digital health solution that you're going to deploy, especially in public facilities, Mr. Mbaka, who couldn't be here today, but we have a technical working group within the Ministry of Health, which is based on e-health. So they're able to preliminarily look at your solution as a technical working group, which has representation from different players. Beyond the technical working group, they're able to provide input. And one of the inputs, they are looking at data protection issues to do with ethics in general. So beyond the technical working group, then there is an e-health technical subcommittee within the division for e-health at the Ministry of Health. So this technical subcommittee basically looks at your system in detail in terms of storage, in terms of access to patient data, etc., etc. So there is a technical subcommittee within the division for e-health. So they're able to come and visit your system at play, see what other considerations you're taking in place to make sure the patient data protection is rather the patient's data is really protected. And lastly, this is where the work between the different ministries and government agencies is very important. So the agency in Uganda that is in charge of IT data protection is NITAU, which is the National IT Authority. So they're the ones that are charged with providing sort of like a confidence certificate to your solution to say that you're able to protect the patient data better. And then you come with this certificate to the technical subcommittee at the Ministry of Health for the final approvals. So from where I sit, because where I sit is looking at different global health partnerships that are UK-led coming into Uganda. So oftentimes we find challenges of where, especially around storage, you have this big digital health solution or digital health organization based in the UK that is coming to implement a solution here in Uganda and accessing patient data. For private facilities, they might not have a challenge because then that is the discretion of the private facility. Once they have maybe a data protection certificate from NITAU, they're able to go. The biggest challenge here, I think, and I'm glad that Dr. Ayume is here, is about storage of patient data. So if you have cloud storage, and Moses, you know this, if you have cloud storage, we do not have good data centers in country, and this is also a business opportunity, I think, on the other hand, to see how do we provide localized data storage centers. Because oftentimes you find that most people are using Amazon Web Service. I think the others are like Azure, which are not best here. Well, they are very good at having those ethical considerations, but the fact that you're going to store data for patients outside the country, it doesn't give a lot of confidence to the regulators here. So oftentimes good solutions cannot take off because of that circus. And it is rightfully so, because even in systems like the NHS, we had a scenario, I think in 2009, where patient data was sold to big pharmaceutical companies based in the US. So that was a big ethical consideration. And I think, so the regulators here are rightfully right when they really consider themselves to be more pertinent around that. But it shouldn't stifle innovation, especially for local innovations. I think what you asked earlier was how do you strike a balance between local innovation, accessibility to these solutions, and data protection. So the innovators themselves should take that into consideration. And for me, because the biggest ethical issues come around storage, where the regulator does not have control of where you're storing the data from. So if the ultimate solution could be having local data centers that can provide that cloud storage, and maybe NITAU could provide this as well, could be a game changer. Lastly, we have, a colleague was mentioning about artificial intelligence, and I think big data. I think there is now penetration of such centers. One of them is the African Center of Excellence for Bioinformatics, which I think the team at STREAMLINE, since they are collecting a lot of data, should take interest in. So working with such centers to provide these extra facilities would be a game changer. I want to keep it at that. I think my colleague would add on the other aspects of ethics.
Thank you. Mr. Wentz, we've run out of time. So can you take 1 minute and no more to just quickly answer that question, and then we can allow the honorable member to close the meeting for us. Thank you.
Thank you so much, moderator. I think the good thing he has covered what I think we needed to cover here. But for me, what I would like to re-emphasize is that yes, the government has made, actually there is data protection and patient safety. There are guidelines on this. So for me, what I would like to re-emphasize is that the innovators in this sector, even including STREAMLINE, you should make sure that you are able to comply with the safety of this data, because it is a very critical issue, and it It includes things you can do at a system level. Are you doing the proper encryptions? Can someone just get the database and access the data? So you need to look at the technical implementations and ensure that you have good ticks there. I'm sure Sam has looked into this, but also look at the training, because whereas you equip this staff in these hospitals with this system, with this data, it does not mean that when an outsider asks for data, they should just share. You should also educate them. If you are to share, who is the accountability person in the facility, you have to educate them. Because once they share information outside and it goes viral, then the accountability person in the facility faces it. So you have to educate them, train them on which data is shareable, which data is not shareable, which processes to take, and also the system should have proper rights so that the accountability person can issue rights, who does what and who accesses what. Thank you.
Thank you very much, Mr. Wentz. And I really, really like that concluding note, which basically from what I hear you say is that there are different roles at different levels. At government level, there is the need to address regulatory gaps, but there is also the organizational level where there is need to adopt best practice. Because the truth is that as much as government needs to play a role, we need to think as Ugandans, as Africans, and take responsibility for the data that we are collecting and manage it up to best practice standards. So on that note, I would like to conclude this session by saying thank you very much to our very well-informed and expert panel. Please give them a big, big round of applause. Yes, and I would like to now just hand it over to the MC. Thank you very much.
Thank you very much, Mr. Moses Waweru. Thank you with your team of panelists. Another hand clap, ladies and gentlemen. I just needed to get some details about Moses, because his other name in some songs means we are outside. Tuli waweru. We are outside. Ladies and gentlemen, we were privileged to be joined by a honorable member of parliament who is going to lead us into the closing sessions. And this is where we are. I am going to request my co-MC to come. Just for a quick consultation. The MP we have amongst us is Honorable Dr. Charles Ayume. He is the MP for Koboko constituency. Dr. Charles Ayume is a medical doctor, but he's the chairman of the Health Committee of the 11th Parliament. He is a resource allocator. They allocate resources. And he is the person who is standing between us and the National Health Insurance Scheme. Because as a chairman of the committee, even just going to NTV and saying, we are waiting for this bill, the cabinet will start panicking and say, this man has talked. But of course, we know that he became an MP on the ticket of NRM, so he may not be interested in making statements in public, which will put his principle on bunkenke. Honorable Dr. Charles Ayume, you're very welcome to this gathering. We are going to invite the Chief Executive Officer for STREAMLINE to come and give closing remarks. And I am going to request the management team of STREAMLINE, those who work with him, to come and stand around him while he gives his gratitude remarks, closing remarks, and thereafter he will invite the Honorable Member of Parliament, but also Chair of the Health Committee, who has taken very serious notes about Streamline. But I was told in the morning when we were anxiously waiting for him that he has some messages to give to the people on National Health Insurance Scheme. The messages may even include that we are still waiting for it, but there are more. I don't want to put words in his mouth. May I now invite Dr. Samuel to come and give his closing remarks, and invite the team that works with him on management to come and mumushagatire. I don't know the word, the kushagatira in English, to accompany. And he's at liberty to introduce them to the Honorable Member of Parliament, who is also the Chairman of the Health Committee, just in case we may wish to put in our request for additional resources to do rural health financing.
Thank you very much, Dr. Ronald. At this rate, I may have to do my PhD so that I become a doctor. Every conference I go to, they address me as doctor, but I'm not a doctor. I'm a computer scientist and a social businessman. Yeah, so I want to thank really everyone for being here today. Let me ask the management team to come here. I want to ask our CTO, our impact managers, our head of software development to come here, and the directors for people to know you. Please come up, and then we'll wind up. And I know the energy is low, but we'll have to stop at a very high note. So we'll again stand up and do the exercise of Wazima together so that we can energize for these last few minutes that we are here together. May we please stand up and remember the slogan for the day. Wazima together. Wazima. Wazima. Fantastic. Do you want to repeat once again? Now with a more, you know, when runners, you see runners when they are in the middle of the race, they lose energy and they slow down. But when you see the finishing line, you see them accelerate once again as if they are starting. So let's have that energy of starting. Wazima together. Wazima together. Wazima together. Fantastic. Thank you very much. Yeah, let me begin by introducing the team at Streamline here. Now we are a big team, but I have just picked the management and the directorship team. Maybe let me begin with the team that is behind there to wave to me. We have a very big team. We are a team of 24. Dr. Kasia has also joined our team, so we are glad to have him. We are a team of 24. We have people in the customer success department who are field engineers who go to the last mile bringing technologies to the rural communities. We have teams there that are software developers. They develop all these technologies. And we have also the administration team that leads us and does the financing and makes sure that we are fine. And our teams are based in Kampala here. We have a base here in Kampala and in Mbarara, so in two different locations. And now that we are going further in the east and the north, I think we may have to set up some support offices to reach the clients even much better. Yeah, so here we have what I call the management team. I have the operation managers. They can step forward and wave. We have Lydia Asimwe on the other side, who is our operations manager in charge of people, and Jacqueline Katongole, who is our operations manager in charge of impact. And then we have the head of our customer success department, Titus Turinawe. He's here. He's the one who receives calls at 2 a.m. Does a fantastic job. Then we have the head of software development, Brighton Yonzima, who is busy doing the codes. And then we have, our CTO, the Chief Technology Officer, Faisal Vega. who is also a director. And then we have our medical clinical leads, Dr. Ian and Hannah Spillman. They do the clinical bit and very, very sharp on the clinical bits, making sure that we don't miss even a single thing on the clinical bit. Very, very central to why Streamline is clinically excellent. And then we have Martin here and Amos, who are also the directorship team that are also here. So as you can see, I work with a very good, wonderful team that has enabled all this to work, and I thank them very much. They'll ask you to take your seats, and please give them a round of applause. I think at our company we value a lot creativity, we value honesty, we have a very open culture. Some of these guys don't see them in suits today. It's the first time they have put on suits. They come in shorts sometimes, but they deliver the work nevertheless. Yeah, our dear guest, Honorable Charles Ayume, I'm really grateful that you have made it today. Today we have embarked on a journey that we started earlier, but today we are officially launching it. A journey to help people at the bottom of the pyramid to access affordable health care. That is what it is about. It is about making sure that the last mile lady in Koboko, whose daily income is 8,000, can also receive a package where they can go to a hospital nearby and access health care. Today we had a number of speakers. We had a keynote speaker, Professor Freddy Sengoba, kicking it off. And he made very wonderful statements. And for me, what stood out is that vicious cycle of poverty and illness. Someone cannot afford to pay for health care, and then waits to go to the hospital. The complication becomes bigger. Now the bill is even bigger. And when they go to pay it, they have to sell their land or part with a very big asset. And he mentioned that there are only 4 options at the moment to help people achieve affordable health care. And there is the National Health Insurance Scheme, which is being proposed. And he talked about other options as well. But he said that the really, just like I also believe, the path for the rural person, I think, is going to be community health schemes. And he mentioned some success stories from Thailand that have worked. And we need to empower these schemes, give them the tools they need, do mobilization, and make sure they do well. Then Dr. Ian Spillman gave a clinical presentation on the clinical benefits of using Streamline in clinical management. Very wonderful presentation. As I mentioned earlier, Streamline was voted as one of the top 5 electronic medical records platforms on the continent. We had a panel from World Bank, and they interviewed us with systems from Ethiopia, South Africa, and we came top 5. And the number 1 reason they said is because Streamline integrates a number of patient safety features and prompts to make sure that the patient is not harmed, which we are grateful for our clinical lead to have led that initiative. Moses Mugume of Chisizi gave us the success story of Chisizi. Chisizi Hospital now serves more than 40,000 beneficiaries across 7 districts in Western Uganda, and these are paying annual premiums between 18,000 and 30,000, and they are accessing health care. You'll be pleased to know that if you're part of a community health scheme at Chisizi and you're pregnant, you get all antenatal visits covered in that costs, and if you have a normal delivery, you top up a co-payment of 60,000 only, and if you are if you have a surgical delivery, you top up 200,000 shillings, which is again very, very cheap compared to what it would be here in the city. But also we want to even make that even more affordable and more affordable for the people. Chisizi also has a mother's waiting home where women who are expecting a few weeks to delivery can come and be in this waiting home. A free service for those who are on the scheme. And The results from this show that mothers actually rest when they come to this mother's waiting home, and that has improved the outcomes as well in the deliveries. Then we had a speech from Stephen Huber Fax, the director of Swiss Re Foundation, and he reminded us once again how the whole world is grappling with two main challenges, the pandemic that we are still recovering from, and now the war in Ukraine that has caused all this inflation. And he said that now more than ever, people need to come together. People need to unite and find more innovative solutions to be resilient. I gave a speech on this project, Revitalizing Rural Health Financing, and I mentioned that with this funding from Swiss Re Foundation, we are going to work with 15 partners who have been chosen from the entire country, and we are going to give them first capacity building support. We are going to train them on how to run a successful community scheme in partnership with our partners at CZ and the other international partners. They will get training both online, in person, and on site as part of this project. As part of this project, they also receive consultant services. Swiss Re Foundation has all the expertise that we need in insurance, being one of the largest insurance companies in the world. So each of these 15 partners will receive consultant services in pricing, in risk management, benefit structuring, etc. Each of these partners is also going to get technological support. We will implement full electronic medical records in both the outpatient and inpatient departments of these hospitals. We will implement STREAMLINE scheme administration platform to help them manage schemes. We will give them a community application where people can save their premiums using mobile money, and they also receive STREAMLINE business intelligence platform so that they are on top of the game and can predict what is going to happen with precision. Each of these hospitals will also receive mobilization support. Each of them is going home with a motorcycle to facilitate community mobilization. The motorcycles are behind there, and after this, most of them will take them. We will fuel the motorcycle for 2 years. We will pay for, we'll give facilitation to the person who will be riding the motorcycle and going to the field. We'll pay for airtime on radios, and we will work with a network of partners to really mobilize people in these schemes, these communities. Yeah, each of these 15 partners who have been chosen across the country, including Rugarama from Kabale, Rushoroza from Kabale, Nkozi from Mpiji, Villa Maria from Masaka, Mengo in Kampala, Chiwoko Hospital in Nakaseke, Bishop Asili in Nakaseke, Ngora Feda Hospital in Ngora District, Koronyi Hospital in Mbale, Bethesda in Soroti, Lira Gift Center in Lira. Whom have I forgotten? Kuruvano, Ruharo Hospital in Mbarara. They are all here. I hope I remembered everyone. Each of these will be supported to build a scheme and hopefully serve 10,000 people plus by the end of this 2-year project. So the goal is that by the end of this project, we will have enabled another 150,000 people to access affordable health care. Wonderful stories, wonderful miracles that will come from all of this. Our chief guest, Ngobi, was very happy, and he emphasized the power of unity, the power of people coming together. There are lots of proverbs which really show that if people unite, they can achieve anything they set out to achieve. And that's what he really emphasized, and the power of cooperatives. And we've had 2 panels that have generated wonderful insights in the area of affordable health care. So now we will wind up this workshop today. And I want to once again thank everybody who made it to this workshop. Thank you for really sparing your time. And like I mentioned, really for us STREAMLINE, we want to be as collaborative as possible. The challenges we are solving are very difficult challenges. They are on the agenda of every government in this world. And that's why we want to work with each one of you to make sure that whatever you can contribute, whatever opportunity you can unlock to make this challenge happen, this work advance, it's very, very welcome, and we are open and looking forward to working with each one of you. Our North Star is that family which you see. I projected a picture of a family. Most of these are female-led. The family I projected, and the husbands, I don't know where they are, but she's there with 4 kids and needs help. So we may disagree on everything, but whatever we do, if we can agree that we provide affordable health care to this lady, we will take the direction that makes it possible to do that. I want to thank you very much. Thank you very much for coming. You can give yourselves a round of applause. And at this moment, I want to invite Honorable Charles Ayume to come and give us remarks, and later a closing prayer from one of us. Have a wonderful evening, and we look forward to working with you all. Thank you very much.
Thank you very much. I'm not so sure who is here, so I will say, distinguished ladies and gentlemen, good afternoon. I'm sorry, first and foremost, that I was not able to come and attend the morning session because I had so many engagements, and but this particular one, I think, was of national importance. Most of you are aware that there's an ongoing strike by senior health officers, senior health officers, SHOs. And we all know that when interns and SHOs strike, they bring the health sector to its knees, because they're the workhorses of the health sector. So I had to run to Parliament to try and diffuse the situation. We had a meeting with them, Uganda Medical Association, and the senior house officers. So it was a back and forth meeting. We had to caucus in different corners, chase out the media, say, go and agree if today you're leaving this room saying that we are going to go back to work. Then we come back in. They say, no, we can't make that decision on behalf of our comrades. They're over 350. So they were making, so it was back and forth, cat and mouse. And, but I think we managed to maybe make a few baby steps. And they told us that if they can get a commitment, they'll go back to work. So I think tomorrow we have another meeting with Ministry of Health, Ministry of Finance, and it's all about payment. They have not been paid in about 3-4 months. And I'll say shame on us, because now I'm part of government. Wonder how colleagues can give a service and are not paid for 3 to 4 months. But I hope, I'm saying shame on us, but I hope this remains here. I know some of you people may be broadcasting that the chairman of the health committee is saying shame upon government. You know, I'm part of government, but yes, sometimes when we fail, we take the blame. So it's something we're trying to do, but I think it boils down to a bit of poor planning, poor forecasting, and so many other issues. So we, as government, we like knee-jerk reactions. But I think in the months to come, as a chairperson of a committee, we have to have deeper conversations with Ministry of Health, Ministry of Finance, and go back to the production line. The production line is the medical schools. We need to know how many doctors are being produced, how many do we need, how many interns are being produced, how many turn into SHOs, and so forth. So we have to go down to that detail. You're talking about community health insurance. I think it also boils down to detail, meticulous planning, and how you capture data. If you don't address certain issues, the very good story that you're trying to pitch and put forward may not be very sustainable. Once again, my name is Dr. Charles Ayume. I'm the Member of Parliament, Koboko Municipality, and I chair the Parliamentary Committee on Health. Maybe just a recap. What are the roles of an MP? Because we need to understand what the roles of an MP are. Some of you people judge us on flimsy. When we don't attend barriers, you start saying, no, our MP is not performing well. When we don't contribute to your weddings, you judge us. Our cardinal roles are 4, and when I took oath, it is to legislate. One of them is legislation, and you're talking about the National Health Insurance Bill. That is legislation. Second one is appropriation, the national budget. You have a loaf of bread, you cut. How much goes to the firstborn, how much goes to the father, how much goes to the mother, and so forth. So appropriation is, you look at the budget as a loaf of bread and then we start slicing. This is for the road sector, for energy, for health. Representation, we represent our people. I represent the people of Koboko Municipality. But my second constituency is the medical profession. I'm also in there to push forward the interests of the medical fraternity. And then the last one is oversight. That's why a number of times we are out all over the country, the community. We may not have been to Kisizi, but I think there are some health insurance schemes we have looked at. I think in Ishaka, in Luwero, and so forth. If you give us an invitation, we shall definitely come. Social health insurance. No doubt you don't have to convince me about the merits of having a social health insurance system, and that comes to national health insurance and community health insurance. We are convinced, like most of the Ugandans, including people on my health committee and members of parliament. However, I just want to demystify that sometimes many people think that social health insurance, in particular community health insurance, is our magic bullet. That once we get a form of insurance, whether it is national or community, then our problems in the health sector are solved. But I must say that is not true. That is just one aspect of our health system, domestic financing, and the other benefits that come with insurance, like pooling, solidarity, and pooling of resources for a future risk. What would be the drivers of community health insurance? Why are people gravitating towards community health insurance? And what opportunities can we leverage on? And I think one of them is need for a service. You go and get insured because there is a need for a service. There is a gap, which gap is caused by no public facilities. Or if there are public facilities, then they are lacking, they are wanting. Long waiting times, X-ray services are down, diagnostics, labs and all that. And then people with similar aspirations. You find in the Bushenyi area, there are tea growers, similar aspirations, similar socio-economic direction. It's very easy to mobilize people along those lines. And then, of course, I said no alternative by government. When the government system is failing, then people seem to choose another alternative. I'll come down to the National Health Insurance Bill. The journey of national health insurance started way back in, I think, 1988. I think half the people in this room were not yet born. 1988, that's when people at the Ministry of Health conceptualized and started planning the blueprint for a form of national health insurance in the country. 1988 to now is how many years? How many years? 30? 35. Yeah, it's about 35 years. And this is, for me, this is the longest pregnancy I know on record. The gestation period of 35 years from conceptualization, 1988, and we have not yet delivered this baby. So it's incumbent upon my committee to will this baby to the labor suit, I mean to the theater for a cesarean section. In my term of office as chairman, we want to really see that at least we deliver the national health insurance. My predecessor tried it. It came to the floor of parliament. It was debated. I think it was smuggled back to cabinet. So we are trying to tease it out of cabinet to come back to the floor of parliament. Last week I was in Rwanda for a benchmarking trip with 4 members of parliament. And there was another 4 members of parliament from my committee that I sent to Tanzania. We decided to keep it local. We don't have to go to Belgium, Kazakhstan, Ukraine, or France, countries that have had insurance schemes for hundreds of years. We decided to keep it local because same communities, same socioeconomic status with us, our neighbors from Rwanda, so why do we have to go to France to benchmark? So we decided to keep it simple, and it's working. We've been to Rwanda, it's working. Community health insurance, the biggest of the 3 funds, and how it is run, what have been their challenges, what have been their mistakes, lessons learned. Same with Tanzania. If you just had, let me give you an example. There are about 1.4 million borders in this country. If each of, let's say if we took 1 million, if we took 1 million and asked them to pay a premium of 100,000 annually, that would be how much? Pardon? That would be about 100 billion. 100 billion shillings. Just from one cohort, borders. And we all know that borders are the biggest culprits in the accident and emergency room. My apologies to any border rider here. I know you may be earning your bread from that, but I presented a report to Parliament in November. Causes of accidents in emergency rooms, and I started with Mulago. 40 accidents per day in Mulago. 80% are borders. So I was trying to do a costing and see how much are we spending, because resources are never infinite. If we do not control upstream factors, we're wasting our time. Even hitting that 15% Abuja declaration, if we don't go back to trying to mitigate what brings people to hospital, then we're wasting our time. So I had to project this on the floor of parliament, and I said the health sector is blamed for its inefficiencies, but the problems sometimes start in other sectors. Accidents start in the transport sector. So when I put that, members of parliament were astonished, because it takes about 3 million shillings per day to treat a critically ill border rider. If he goes to ICU, that's another 3 million shillings per day. So for us to be able to treat people in this country who get accidents annually, we needed 315 billion shillings. But I know as the chairman of a health committee, I don't appropriate that for accident and emergency. I think I appropriate like maybe less than 30%. What happens to the rest? Poor prognostic outcomes, high out-of-pocket expenditure. You have to do fundraisings for people in hospital to buy prosthetic, rather implants and all that. And then the unfortunate ones die. So there are 3 outcomes. So why don't we go upstream and mitigate that? But going back to the issue of insurance, I said this industry, borders, if you just ask them to pay 100,000, and some of them here in Kampala make it in a day. But you're saying pay that in 1 year. You could get 100 billion. 100 billion is what Mulago needs to operate at optimum level. So I'm just giving you avenues for domestic financing. But what I noticed in most of those countries that we have visited, I think there is strong will. And by strong will, I'm not going to mention what kind of will. If you're intelligent and you're in this room, you know what I mean when I say will. The will that comes from the top. And it cascades down to the community. Once a person at the top sneezes, everybody is supposed to catch a cold. So strong political will affects governance at all levels. Because when you pull this kind of money, it's a huge basket, it's a huge resource basket. If you're looking at it at the national level, community health insurance at the national level, it's huge money. So if you're going to get people putting their hands into the till, we already see what's happening with NSSF. That's just NSSF. Now what we're talking about are national health insurance. So if we don't strengthen our governance structures, then community health insurance, national health insurance may turn out to be a disaster. So as a member of parliament, we embrace insurance, but we also have the responsibility to ensure that there are controls, there are checks and balances to ensure there's accountability. As I conclude, you see, when you take somebody's money and you tell him to pay monthly, I'm talking about insurance generally. I'm not only talking about under the faith-based health facilities. If a health center 3 or 4 in Koboko is not functional, by not functional I mean you cannot go and get a cesarean section done, you're diabetic, you can't go and get a blood glucose done, you can't get diabetic medication, metformin, glybenclamide, and so forth, and yet somebody is paying a monthly premium. There are two options. You'll either get a nationwide strike, or people will opt out of the scheme, or those who are in this, or you'll not be able to convince more people to join the scheme. So we have to make sure that at the national level that we have to bring public health facilities up to spec. Up to spec means renovating the dilapidated infrastructure, equipping the facilities, staffing them, and ensuring they function at optimal levels. And I'm not embarrassed to say this, that in our countrywide tours, there are facilities you go to run by, they are faith-based, by the church, like Matanyi, up to spec. You go to Lacho, up to spec. Kisizi, I've not been there, but I've heard good things about your facility. And it gives people confidence to subscribe to the scheme. Now, if we are to roll it at a national level, the onus is now upon us to start running to ensure that we refurbish the infrastructure. As a member of parliament, in my first term of office as a chairman of a health committee, one of the things we have run away with was salary enhancement. We have increased the salaries of health workers, and I think right now they smile a bit. Of course, sometimes the taps go a bit dry, but we can ensure that interns are getting a much better pay, medical officers are getting much better pay, and consultants. Now, the issue here is how do we ensure that public facilities with a staffing gap of 40% or 60% are maybe staffed up to about 80%. We have procured CT scans. And everybody seems to be very, very happy that, oh yeah, we have the CT scans. But we forgot one fundamental thing. Not forgot, omitted in our planning. We have not recruited radiologists. So the CT scans are there. Now next year we have to look for money for radiologists. Because you need somebody to interpret what you're shooting. And then after that, why do you need the CT scan? You need a neurosurgeon and so forth, and you know. So it's a whole complex web. And but we are up to the task. So when you're looking at the healthcare system, look at it in so many dimensions, not only funding. You need to look at it: infrastructure, equipment, governance, human resource. Some of the areas where we have put CT scans are off the national grid, like West Nile, where I come from. You need 3-phase power to run those machines. They need to be in an air-conditioned room, ambient temperatures. So we cannot turn on our CT scan until Karuma Dam is finished, until we get pylons from Karuma, 160 kilometers away, and we are connected onto the national grid. So there are some things that are outside the health sector. They're in the energy sector. So let's look at it in 3 dimensions. So I'll just conclude by saying we don't have a legal framework that superintends over national health insurance, even community health insurance. But I think as government, we have given it a blind eye and said, if it is working, why stop it? The onus is upon us to ensure that we get this piece of legislation up and running, so that when you're doing community health insurance, what Ubuntu is trying to achieve, you know that you're working within a law. And when you're working within a law, even your funders are a bit more comfortable. Because, I mean, if you run to Switzerland to ask for supplementary funding, you know, somebody can flag it up on a very technical issue, but where is your legislative framework? So it's incumbent upon us, Health Committee, to ensure that we have this long-awaited baby delivered. And finally, I would just want to thank everybody. You have done what government should have done 10, 20 years ago. And that's why I like the private sector. Sometimes you're ahead of us. You're ahead of us 20, 30 years. And then we have to start running after you. But it's important. It's good to always have checks and balances. It's always good to have constructive opposition to ensure that it keeps us on our toes so that we can do the right things. I would like to thank everybody, all those who have traveled from far and wide, the various hospitals, and thank you for doing us proud, and for your noble duties of trying to give health services where they're inadequate. Thank you very much. God bless you all. I would like to declare this meeting closed. Thank you very much.
Ladies and gentlemen, another round of applause to the Honorable Dr. Charles Ayume. Thank you so much for gracing this event with these closing remarks. Ladies and gentlemen, we have come to the close of the STREAMLINE Ubuntu launch event. We thank God for making it a huge success, and thank you so much for gracing this event with your presence. As I prepare to invite Madame Christine Makobole of UPMB to lead us in a closing prayer, as she comes forward, I also want to announce that evening tea is already set. It's right there. So before you walk out of this room, pick your coupon and first take a cup of tea. And then we wish all of you safe journey masses as you travel back. Please, let's stay in touch. The partnership goes on. Madam Christine, please come forward. We are so happy to have you. Thank you so much.
you so much. Let's humble ourselves for a prayer. Father, Lord, we want to thank you for this day. We want to thank you, Father, for bringing us together. We want to thank you for the brilliant minds that you have brought today, for the plans that we have drawn, for every activity that has been put in place today. We want to thank you, Father, that you have enabled us to be leaders in our communities, for serving you. We thank you, Father, for the person, the last person, the leader in the community, that chairman that goes mobilizing other community members, Father, for the work they do, up to the highest leaders of this government, Father. We want to thank you that you have enabled us and you have given us the opportunity to serve you. And Father, we put into your hands the plans, the work that we are doing, that you may bless it, that it may reach the last person that needs these services, Lord. And we commit to you this evening as we go back to our respective places. Give us protection on the road and whichever means we'll be using. And Father, we want to bless you for the food that is before us. In Jesus' name I've prayed.
Wazima together. Safe journey as you go back. God bless you.
There are those who did not receive the t-shirts, Streamline t-shirts, for better visibility. You will have to talk to Amoding, Joan, and I have been assured that all the people who are in here are God-fearing enough that they will not get a second serving. Please make sure that you get a t-shirt, a Streamline t-shirt. The Streamline t-shirts are not hydrophobic and they are durable. Please pick one before you leave, and thank you very much. We will meet here in a couple of months to showcase the successes of what we have launched. And be sure to join us as we share the successes together.